Can we start now?
And wait for a few seconds.
Yes.
You can start, ma'am.
Thank you. Good evening and welcome you all on behalf of Oralab. And I also thank AOS for giving us this opportunity to conduct this very important webinar on an important topic, cluster endophthalmitis. And it's completely different from isolated endophthalmitis. It's an incidence. This is a nightmare situation for any surgeon. And it not only involves surgeon, we have to need a multidisciplinary approach along with the industry as well as our ophthalmic associations and of course the legal and other state authorities also we need to include, and I mean we will be included by them, and we have to face the judiciary as well as sometimes often unfriendly media, and everything has to be handled in a different way. So it's not as a clinician just to treat the patient is not enough in such a situation. And that's why this Oralab especially, they were very much interested in conducting this particular topic as a webinar. And here we have a very apt panel for this particular situation. I'll start introducing them. Dr. R.D. Ravindran, the chairman of Aravind Eye Care System, whose obsession with quality is well known within Aravind, and of course, he is the guiding force for us all to stick on to this. And also, this is a very a topic which is close to his heart, endophthalmitis, especially cluster incidents. And so he will be guiding us from the institute point of view. And we also have Namrata and Dr. Sinha, and they will be the most dynamic AOS team who can guide us what the association can do for us, and in such a situation, how it is going to help us. But unfortunately, they will be joining a little late only because they were involved in some other meeting. And we also have the two eminent people in the NABH guidance as well as the quality control. They are well known all over India, Dr. Nirmal Frederick, as well as my co-moderator, Dr. Chandrasekhar, who will be guiding us about the what we have to do once the situation occurs, what we have to do, and also before the situation occurs, how to stick on to the quality control measures, which will help us a long way in facing the various authoritative procedures. And also Dr. Haripriya Aravind, I welcome her because she is the leader of the cataract team here in Aravind, and also her work on preventive measures for endophthalmitis and cataract surgery is well known, well received, not only in India, world over, in ACRS, everywhere. Recommendations are being followed everywhere, all over the world now. So with this introduction, I welcome my co-moderator, Dr. Chandrasekhar, will start the session. We have designed the session in such a way that we will also talk about what we have to do clinically once the infection is recognized, and also the routine protocols and preventive measures, what we have to do, and why we have to talk about it. This documentation and sticking on to these protocols will help us in a long way, even in case of a cluster endophthalmitis, to face the various actions later. And later, Dr. Lalita and Dr. Chandrasekhar, they will be guiding us once the infection incident occurs, how we have to go about it. And in between, our panel will discuss and guide us also. And Mr. Krishna Kumar will talk about how an industry can help in such a situation for us. Dr. Chandrasekhar.
Thank you very much, madam, for the introduction. So it's a pleasure and honor to be part of this wonderful conference, the CME program and cluster endophthalmitis, how to handle it. Now it is my honor and privilege to invite our chairman, Dr. R.D. Ravindran sir. He needs no introduction already. Madam has told about him. He has led many teams and he has been part of committees which have developed guidelines for infection control, not only in the state, across the country. So over to you to give the keynote address, sir.
Thanks, Chandrasekhar and Revati, for this opportunity. I'll just share my slides in a minute. Yeah. Can you see the slides?
Yes, sir.
Yeah. Okay. Can you see it?
Yes, sir. Slide show, sir. Slide show.
Okay. Thanks again to both of you, Dr. Chandrasekhar and Revati. I mean, this is an important area, the cluster post-operative endophthalmitis, because an incident like this can really affect any organization, the sustainability and stability of the organization or a private practice. So it's important that we avoid such a situation in our practice. If you look at the end of the post-operative endophthalmitis, it could be sporadic or a cluster, or it is also called as outbreak when you have a group of cases. So when you come to the sporadic endophthalmitis, they are very different. So the sporadic endophthalmitis, which we see on and off, there are very few cases, can be separated from time to time, and usually occur very irregularly, haphazardly, and it's usually very infrequent thing. And you cannot connect to cases of endophthalmitis to any single cause. And they also show very little connection with each other or a recognizable common source of infection in case of a sporadic endophthalmitis. And often the organisms which cause sporadic endophthalmitis are gram-positive organism, and usually the gram-negative is around 20% or less. And there are a lesser incidence of fungal being the cause of sporadic endophthalmitis. And they are usually mild, and it is usually easy to manage these patients. Whereas the cluster endophthalmitis is defined when you have 2 or more cases of endophthalmitis occurring on a particular day, especially in a single operating room operated by 1 or more surgeons. Or it can also occur over a short time interval due to a common cause in a OT complex over a period of time. And it is when you have cluster, it is usually bacterial, and very often it is gram-negative, rarely fungal. When this fungal endophthalmitis occurs when the cases are separated by a time period. No, it occurs over a period of time, not on the same day. When it occurs on the same day, it is usually bacterial, and it is gram-negative. And the cluster endophthalmitis, as I mentioned, it is usually very acute, and it occurs between 24 to 72 hours in most of the cases. Either the signs and symptoms, both are very profound. The pain will be very severe. Diagnostic criteria for endophthalmitis, and the patients will have very profound visual loss, whether it is congestion, chemosis, lid edema, or anti-chamber reaction or hypopia. They are all very profound. And in sporadic endophthalmitis, the culture positivity is somewhere around 25 to 30% in most institutions, whereas in a cluster endophthalmitis, it can be anywhere between 80 to 100%. So both the vitreous and the aqueous grow the organism in cluster. So that's a major difference. And I just would like to highlight this cluster endophthalmitis. It happens often, and it gets reported in the media. The year 2008, there were 11 instances, and about 165 cases were reported. This is from a government communication. So wherein they also, as per the government communication, they also have isolated the organism from finger lactate and viscoelastic, and there was also a directive at that time that we autoclave all solutions, including the viscoelastics. And in the year again, there was in 2014-15, there were 1 or 2 instances. So the government had collected all the instances and reported about 9 instances which happened, which are brought to the government notice, and wherein about 204 of the 527 patients operated in 9 instances had endophthalmitis. So they occurred in different places in the country. So this happens every year, at least several times. Even recently, we had 2 episodes of endophthalmitis which were reported nationally. And if you look at the predisposing factors in all these instances which have been reported, they have either pointed it to us deficiency in sterilization or contaminated irrigating solutions or viscoelastics. As you can see in this picture, you can see a kind of a coagulum of fungal ball in this bottle. Now, so unless you really monitor these things on a regular basis, you cannot be able to pick it up. Or it could be due to contamination of the internal tubings and the phacoemulsification. And the operation room hygiene and also contamination of the ventilation system also can play a role. So I'll just share some my personal experience with a few cluster endophthalmitis. This is talking about one cluster of 8 cases. All happened on one OT, where 18 patients were operated on a single day by 2 surgeons. One surgeon operated 17 patients, the other surgeon operated 1 patient. So the first 5 patients of the 18 were phaco, the rest 13 were small incisions. So all of them were uncomplicated, no PCR or any need for vitrectomy in this group of patients. On the subsequent day, on the second day, during the postoperative period, 1 patient was seen to have developed postoperative endophthalmitis. This patient was seen on the morning. The patient was held back for uveitis, and the next day he presented with endophthalmitis. And second patient came in the evening with feature suggestive of endophthalmitis. So there are 2 patients. Hence, the rest of the 18 patients were called. And then what we found was the first 4 patients who had a phacoemulsification had developed endophthalmitis, and there was no sign of infection in the 5th patient who again had a phacoemulsification. Among the small incision cataract surgery, the first 4 patients had developed. So all were pseudomonas endophthalmitis. So this is the sequence of the 18. The first 4 who had a phaco had endophthalmitis. The 5th there was no endophthalmitis, and again the next 4. So usually we operate on 2 tables, and both the tables the patients had endophthalmitis. And of this, about 3 patients had poor outcome. So when we looked at the possible cause, on a particular day, 8 sets of instruments were used. So which means these 8 sets of instruments were autoclaved, which had undergone a long cycle autoclaving the previous day. So only the patients where we had used the fresh sets had developed endophthalmitis. So the 8 sets, 4 were meant for phaco. So those 4, the first 4 developed endophthalmitis. Then the 5th case was operated by a set of the same instruments, but they were autoclaved. They underwent the flash autoclaving, and it was in the same trolley. The trolley was not changed, but only the instruments were autoclaved and brought back, and they were used. And that particular patient did not develop it. Then subsequently, the next 4 cases were operated with the instruments that were meant for SIC. So there was some deficiency in the long cycle autoclaving that was done on the previous day. So that was the clue. So what is the lesson we learned from it? That is, the documentation is very important. The indicator we use for documentation is very important. So we were using this class 1 indicators. So this class 1 indicator, even with the minimal change in the temperature, the indicator tape can change, and it does not indicate the pressure. So there was a time we also switched over to class 5 indicators, where you need both the temperature at a certain level and also the pressure. So now, as a result of this incident, we switched over to this, and whether it is a long cycle or a short cycle, this indicator is used for every load or every bin it is used. So this is one important lesson we learned. The second is the involvement of the OT staff. The particular day when this incident happened, the staff were not very happy about the bin. So when a set of instruments all have undergone a full cycle autoclaving, they really have the feel of the towel and the instruments, all of that, which was missing in this case, even though the sterilization marks were appropriate. So because of the assurance given by the CSST staff, they autoclaved it. So and from that point, any doubt we have, we kind of resorted to re-sterilization. At least I personally at least on 3 or 4 occasions where we had a doubt. We were not very sure because the printout was not clear, or some indicator, one indicator is not changed, so we had re-sterilized it. And again, this also enforced the belief that cleaning the autoclaving instruments between surgeries is effective. And we cannot, even though we had the same instruments were placed in that particular trolley, but when we use the same, nothing happened. So which also shows that the clean autoclaved sterile instrument is more important than anything else. So that's the first thing. The second is a cluster of 12 cases which had endophthalmitis. That was all operated by one single surgeon. He operated 24 cases in the same OT. There are 8 cases he had operated phaco, and then followed by about 16 cases of manual SACS. Of this, one patient had a PCR and also had anterior vitrectomy using the same machine. So if you look at the course of events, the first case was seen on the second day, the second case was seen on the third day. So based on that, all patients were called back. All 24 patients were called back, and 10 of them showed early signs. In addition to this 2, 10 of them showed very early to establish post-operative endophthalmitis, and many patients were reluctant to come, saying that they are doing well. When we called them and we found them, they had early signs of endophthalmitis. And giving an intravitreal antibiotic at that point of time was very useful. So that, and all the cases which were operated, the 8 patients who had phacoemulsification and the 4 patients who had a small incision developed acute endophthalmitis. The 8 of them underwent vitrectomy, and 4 patients were given intravitreal antibiotic. And there was no need to, none of the patients went for phthisis or no PL. They had a poor visual recovery, less than 5/60 in 3 cases. Rest of the patients had 6/60 or better. And the possible cause, we were able to culture the same pseudomonas which we cultured from the vitreous, also from the internal phaco tubing. So with the similar antibiotic sensitivity pattern, which we feel could be the cause. So whatever there was a contamination, this happened long time back, like 15 years back, when this used to be a problem. So one of the small incision cataract patient had a vitrectomy using the same machine, also had developed endophthalmitis. We feel the other 3 patients who had small incision patients who had this, also in some way the doctor had used the IA unit of the machine for removing the lens material. So all of the patients wherein we had used the phaco machines had endophthalmitis. So this could be, possibly this could be due to, that was a time when we used to clean and reuse the phaco tubing. Okay, so this could be possibly that there could have been leftover water, that the tubing were not completely dry. They were not, the cleaning was not appropriate. And this, which means, you may not, this ETO may not properly sterilize such tubing. So, or it could be due to the contaminated internal tubing which should have caused this. So we were not very sure either of this could have happened in this particular case. So one of the important lessons we learned in this is that ensuring that we recall of the patients. Some patients who were not willing to come, we sent our own vehicles to pick them back and bring them to the hospital or examine them there and bring them. And it is important that we ensure everyone is re-examined in spite of their subjective status. And that is also the point when we stopped reusing the disposable tubings that cannot be autoclaved. If the disposable tubing, if a tubing has to be, only we started now, wherever we were using reusable tubing that can be autoclaved, we used them. If it has to be ETO'd, then we gave it away. We also understood the importance of cleaning and drying of the tubings. Still, some of the retina tubing reusables are all used. So we really make sure that people are well trained to do this part. And again, there could be a possibility of mixing of unsterile item on that particular day. So segregation also was given a lot of importance. So these are some of the lessons we have learned from this particular episode. And I also would like to share with you a cluster which occurred over a period of time, which we had to handle. So initially there were 2 or 3 patients who were seen, but subsequently over a period of 3 months, 12 more cases of endophthalmitis were seen by us. And all of the patients were operated at the same hospital, but they were all operated by different surgeons. As you can see, the average time of presentation varied anywhere between 12 days to 90 days. So this was the case. And these are cases are very difficult to understand. So all of them had undergone phacoemulsification. Some cases presented with uveitis, some had hypopion, some of them had only without any hypopion, they had metiases. Some patients presented with infiltrates in the corneal wound. So there was a varying presentation, and we were very confused with this particular presentation of cases. And we had a detailed microbiological investigations of the whole system of that particular hospital was done by our team, which Dr. Lalita will present, share in that presentation, because it's a very detailed thing. She will cover it as part of the root cause analysis, and there's a lot of learning for all of us from that incident. So, I mean, if you look into the literature, there are several articles that have been published on cluster endophthalmitis. Here, they've reported Pseudomonas aeruginosa endophthalmitis caused by contamination of the internal pathways of the phacoemulsifier. There is a paper that talks about trypan blue being contaminated and used. These were all compounded trypan blue in the early days, when it was not available. They were all made in the local pharmacies. Similarly, there is a report from Turkey wherein they talk about irrigation solution being the cause, where they were able to isolate the Pseudomonas aeruginosa. And Pseudomonas is a very common contaminant. So this is where it is really important not to use tap water in our operating room. It's always better that we use RO water. Make sure that all your hand cleaning, washing, instruments. We also use additional filter, wherein we really get a pharmacy quality, injection quality water, which we use for cleaning the instruments. All of that have made a big change, a tremendous change in bringing down the endophthalmitis in our setup. So to summarize, the cluster infections are always infective, and it is always possible to find the source. The sad thing is, when we look into those the reports I earlier showed, the 2008 and 2014-15, even though they've described the number of cases and what happened to them, they were not able to find the cause. Why this happened? One is there is a lack of methodical investigation. Other one is not following standardized protocol and not having a standardized way of documentation. So only when you have this, even when something goes wrong, you'll be able to find it. Otherwise, it will be very difficult to find what could have caused this infection. So this is in brief what I would like to share with all of you. Thank you.
Thank you very much, sir. I mean, this is the best introductory keynote address we can have for such a session, with very good examples and also the lessons learned. And also, as time and again throughout this session, we will be insisting on the importance of documentation and following fixed protocols. This is very, very important to find out the root cause and also to correct ourselves. And not only that, to face the judicial process. Only this can save us, the surgeon. This is very important. And I would like Dr. Chandrasekhar, would you like to give any comments on this?
Sir has given a very practical and really very good approach for root cause analysis, which we can see, which has started even 12, 13 years back or 15 years back. So he has been a leader in setting these trends. So these examples will give more input to all the people who are listening than actually talking theory, sir. Thank you so much for your wonderful keynote address, sir. Thank you, sir.
Thanks a lot. Thank you.
Thank you, sir. And we'll move on to the actual session now. The first talk will be by Dr. V.R. Saravanan, our Chief of Retina Vitreous Surgery in Coimbatore, Aravind. And he's the person who will be called often, even anytime whenever we have our own cases, or even when we happen to handle the clusters from other institutes, other places when they are being referred. Any time of the day or night we will be called, and he's the one who used to handle all these cases. I welcome Dr. Saravanan to talk about how to handle these cases once the infection occurs.
Thank you, madam. Thank you, madam. So Adya sir had already given a very practical lesson on how what some of the case examples and how to go about. And are you able to see my slides now, sir, full screen?
Sir, Anand.
Yes, okay.
Yes, we can see it, sir.
So as already sir pointed out, cluster need not be a big group. It can be even 2 cases, especially in a peripheral center where they are operating only a few cases. And more commonly we see in post-cataract surgery because that is the most commonly performed surgery. And in recent times, because the number of intravitreal injection as a therapy for ARMD, DME, vein occlusion has increased proponently in the last few years. So we are seeing cluster infections after intravitreal injection also in recent years. And the incidence scan in post-operative, it's approximately ranges from 0.02 to 0.8, and in injections, it's approximately 0.016 to 0.026%. So it can, as by definition, this can be anything more than one infection in the same theater, or it can be repeated post-operative infection under the similar circumstances where the same surgeon or same staff or same operating room, which is a little bit more than what has been the hospital's performance in the previous years. So like one of the third scenarios which Adya sir shared, we're seeing very distributed cases over a period of months. So sometimes that can also be will also fall under the cluster definition. It may not be on the same theater on more number of cases. It can be a few number of cases scattered over a period of weeks or months also. So anything unusual compared to your previous year's performance, you should always think about a cluster and try to search for the root cause, as these future speakers will be pointing about how to go about it. So as already sir pointed out, the most common organism involved in cluster is always gram-negative, of which Pseudomonas is which thrives under the hospital environment, especially because of it comes from the hospital source. The multiple drug resistance also is sort of a standard in cluster infections. And various causes, as sir pointed out, can be from irrigating solutions, from the viscoelastic, and because it thrives in the hospital environment, they are by default multi-drug resistant. So expect multiple drug resistance, especially in a cluster in a hospital setting. So this is some examples of cases which we have treated in a cluster in our hospital, and you can see the typical ring abscess or total corneal melting in the left side of left side picture. So this is what is the commonly seen. And if you look at these basic investigations, it's very critical to do an ultrasound to look at the posterior segment involvement, especially in these cases. Panophthalmitis is one of the norm, especially if they are referred late, and you'll be looking at the typical thickening of the retinal choroidal sclera complex along with the presence of the subtenon fluid, which mimics the scleritis T sign. So, and also clinically you'll be seeing proptosis and limitation of extraocular movements. Even though Pseudomonas and probably Klebsiella after that is the more common causes, we do get some unusual clusters also. This is a cluster of around 8 cases from a hospital in Kerala. Unusual case of Acanthamoeba cluster, which was extremely rare, which was picked up on confocal. This was reported by Dr. Anita from our hospital, very unusual case. So in these cases, we had a lot of corneal involvement, corneal opacification, and also resistant vitritis. It was used to respond to intravitreal antibiotics, then come back again, and we do choroidectomy, it resolves and then comes back again. And most of these patients went in for a very poor profound loss of vision, and a lot of patients lost their eye also, leading to phthisis bulbi. So some of the clusters which have been reported following intravitreal injections, mostly the offending drug is Avastin, because all the other drugs come in single vials and Avastin has to be shared. And all these 3 reports which I have shown here have been from the single vial. So the surgeons shared the drug for multiple patients from a single vial, and they had approximately the cluster ranged from 8 to 24, as you can see here. And the first series from Korea had a Streptococcus species, which was the offending organism, and in the second from India, they had a very unusual bacteria. It's a Pseudomonas Cynotrophomonas maltophilia, which is a very unusual organism to cause in a cluster. And from Kanpur, Dr. Parvez Khan, he reported a series of 8 cases and unfortunately, he could not identify the organism in any of these. We had, and most of the first group, almost except 2 patients, all other patients had a very poor outcome. And the second group, around half the patients survived, and the third group again half the patients survived. So in clusters, you will have to expect a poor outcome by default unless you identify and treat early. Even a slight delay in referral or treatment is going to cause a significant grave poor outcomes. This is some of the clusters reported from India. And you can see, as you can see in the right side last column, Pseudomonas is one of the commonest offender, as you can see here. And next comes Klebsiella and Enterobacter. And the last in the series was a very unusual organism, that is Burgdorferi cepaceae, which was reported from hospital in Madurai and published by Lalitha Madam, who will be one of the speakers in the future talks. This is a very unusual case where the offending source was the topical drops, which was used in a topical. So all the patients who underwent topical phaco developed this. And again, the infection was spread over a period of months because they presented quite late. So these are some of the clusters which have been reported, especially if you have a big group of patients reporting to you within the first 8 to 12 hours, especially if we operate in the afternoon. Tomorrow morning you're seeing a very poor anterior segment. First thing you'll have to think about before you think about endophthalmitis is TAS, because here the cornea to limbus to limbus corneal edema, little bit whiter sclera compared to infections, and the absence of significant vitreous involvement. All this will sort of point you towards that it's not an infection but it's a TAS. So even though Pseudomonas can present as early as 24 hours, it's again very unusual to operate. Within 12 hours of surgery, it's very unusual to see a big severe infection. But some of the Pseudomonas clusters have presented very early also. But still, if you have a very significant involvement with the whiter eye, always think about TAS before you jump onto the cluster infections. So again, the various reasons for TAS, the toxic agents present in BSS, antibiotic injection, or enterotoxin residues, especially in the viscoelastic. So all these can be a cause of TAS, and the onset is much more earlier compared to the infection, compared to all the other. Even Pseudomonas, it usually doesn't present within 12 hours. It takes a little bit longer for the infection to manifest. So when you have a cluster infection, so again, this was will be stressed throughout by all the speakers. So we'll have to document all the positive and negative findings. Immediately, it's better to admit the patient, even if you're suspecting also, because you need to assess the progression, whether it's responding, whether it's inflammation or infection, if you're not sure. And if you're more leaning towards inflammation, you can always start with the high dose steroids. But if you're thinking of infection, it's always best to go ahead with the vitreous tap, AC tap, and treat them with intravitreal antibiotics. If you're not sure, you can admit the patient, treat with steroids, and monitor them and see whether it is improving or not, and then decide the next course of action. So most of these patients tend to have a raised intraocular pressure, which is also a significant component which can cause vision loss. So apart from treating the infection and inflammation, glaucoma also has to be taken care of. So again, this is again the sequence which we commonly follow up in a case of cluster. So after treating, we'll have to report to the concerned authorities, and after that, together we have to look at the root cause and what is the offending organism and root cause, and then all the other things which will follow once we identify how to go about preventing future outbreaks like this. So this is the some guidelines given by the RCO. So again, more or less what will be stressed by the coming speakers as well. So I think I'll just skip this slide so that I think Lalitha Madam will be elaborating on this protocol. So this is what we do. So normally we go in for a gram negative and gram positive coverage. So normally we start with the moxifloxacin. Apart from if it's a very significant, sometimes we start vancomycin and amikacin drops in some of the more severe infections. Apart from that, cycloplegia is a very critical part. If you are sure about the response, once you are sure that the response is improving, the eye is responding to your treatment, you can start your topical steroids. Sometimes we start the steroids immediately along with the antibiotics if the infection is not that very severe. So very critical is to immediately before you start your intravenous or oral antibiotics to get a AC tap and vitreous tap, which will be the main tool to identify the organism and try to search for the root cause. Even if you are having a cluster in the periphery, always it's better to do the AC tap and vitreous tap before you refer, so that sometimes the long time and for the patient to travel to the hospital can be detrimental to the final outcome also. So Oralab is marketing a E-kit or endophthalmitis kit, which contains all the essential, right from the speculum to the cotton swab to all the drugs which are like vancomycin, ceftazidime and voriconazole, and also the chart on how to prepare the antibiotics. Is a totally wholesome tool, especially if in a peripheral center where it is difficult to source all these injections immediately. You can always have these tools at hand. So one box will cover for each one patient, and it has all the required, right from the speculum to the swab to all the drugs and how on the chart on how to mix. So this very good step by Oralab to help all the doctors, especially who are practicing the periphery where it is not easy to source these. So this is how we take a AC tap, just showing a 26 gauge needle is inserted at the limbus. And then trying to aspirate, and this can be squirted onto a blood agar plate and sabrods if it's available, or we can send it to the lab immediately. So dropping it at the theater itself on the media will help you to increase the yield. A lot of times you see that in spite of a frank infection, we don't get positive, and the positivity ranges from 30 to 50% even in the most severe cases. So intravital injections, you can again the chart helps you to prepare this, and for a vitreous tap you can use a 24 gauge needle to 3 millimeters from the limbus. You can just enter the vitreous cavity and aspirate, and then give the intravital antibiotics through a separate needle. In case you don't have a caliper to measure the 3.5 millimeters from the limbus, the 1cc syringe is the base of the 1cc syringe which we use for all the injections is 3.5 millimeters. So normally you can just sort of create an impression on the conjunctiva by rotating that blunt end of the syringe, and that will give you the 3.5 millimeters measurement in case you don't have a caliper and are not sure where to enter. And at the edge of that 3.5 millimeter, you can both take the vitreous tap and give the intravital antibiotic. So once here you give the intravital antibiotic and then assess the response, or if when it's not responding, or if the primary infection itself is very severe, the next step is to go for a core vitrectomy. So to clear, it helps you to clear the media and also give a nice room for the intravital antibiotics to act. And this is the various media which we use for inoculation: chocolate agar, blood agar, both for bacteria and fungi, and the SDA sabrods dextrose agar for the fungus, and thioglycerate broth for some of the anaerobes as well as propionibacterium. And routinely for a non-cluster, we go for vancomycin and ceftazidime as the primary choice for intravital injection when you don't know what the organism is. But in a cluster, especially when there is significant corneal involvement, always suspect Pseudomonas. And being multiple drug resistance, always better to go for a Piptas as the first choice. So in our hospital, whenever we see a cluster, especially when you're suspecting Pseudomonas, Piptas is the first choice. We don't go for ceftazidime, we go directly for Piptas. And once you get an culture sensitivity, in case it's not sensitive to the Piptas, we have the other option. We have imipenem, colistin, and amikacin. Sometimes most of the cases are resistant, but imipenem and colistin has been tried in these cases. Also polymyxin B, both topical as well as intravenous, has been also tried, and there are case reports of intravital installation of polymyxin B also, especially in multi-drug resistant Pseudomonas infections. So this is the sequence. What we do is initially we take a dry tab before switching on the infusion by doing the sort of a dry vitrectomy, and then we try to, unlike the olden days where we do only a core, and nowadays we try to do a much more thorough vitrectomy, especially if the media permits. The reason being that doing a full vitrectomy and inducing PVD helps to hasten the process of recovery. Unlike the EVS guidelines, they did only simple core vitrectomy. Nowadays, if the view permits, we go for a near total vitrectomy. We don't do a thorough base shaving, but we do a PVD induction at least at the posterior pole. Just a small video on how we go about treating these cases. So this, she showed you the AC tap, and then so usually we go in for the MIVS or in microincisional vitrectomy surgery where we don't put sutures. So here, as you can see, the accumulation of the periretinal exudates. Here, usually we try to induce the PVD at least at the posterior pole if media permits. You can see the induction of PVD, which was not the routine when you were in a few years back. So nowadays we are much more aggressive in clearing of the vitreous, because this helps to hasten the process of recovery. So again, it's important to clear the media. Sometimes we do corneal scraping also to enhance the media, removing all the fibrin from the anterior chamber and over the eye veil. It's critical to increase your visibility. Sometimes in cases of suspected fungal infections or nocardia infections and multiple recurrence, we tend to remove the eye veil also. Doing a big posterior capsulectomy also enhances the penetration into the of the intravitreal antibiotics into the anterior chamber and into the back, to leading to better penetration of the drug and killing all the organisms. So this is showing the clearing of the FM. It's critical to clear the media well so that you can do a much more safer and thorough vitrectomy. In some cases where the cornea is very badly involved, we may have to do a temporary K-pro with the keratoplasty also. Some cases we have tried this, especially in the very bad late referrals, especially when the patients in one-eyed patients. We tend to do this temporary K-pro to enhance the visualization for vitrectomy and replace this with the corneal graft also. So as I told you, eye veil removal is not a primary step in surgery, but in cases of multiple recurrences or very fulminant cases, or when you are suspecting fungus and nocardia, especially in nocardia, we feel that removing the bag and eye veil in toto helps to enhance the final visual outcome. We can go for a SFIO later on once the infection is eradicated. Silicone oil, some of the centers use silicone oil as a standard for all the clusters, especially in Madurai also, because the retina is very inflamed in these cases, and vitrectomy can induce multiple retinal SAS and also increase the risk of retinal detachment. So, but here we are not very common, and we don't use in Coimbatore, we don't use silicone oil much commonly, but in Madurai it's standard for all clusters to go for a silicone oil injection. It has got a bacteriostatic effect and helps to clear the media very well, and also helps to take care of small tears, especially in pseudomonas where the retina is very friable and the risk of tears is much more higher. Steroids, as I feel that it should be started as early as possible, because not only taking the care of the infection, but also inflammation also very critical, can cause grave damage to the intraocular structures. And once you are sure that the infection is responding, always start steroids. Both we sometimes inject intravitreal also during the second injection, and starting topical as well as when the cornea is not involved, and also intravenous steroids helps to hasten the recovery and preserve the vision also. So as already pointed out, the outcomes after cluster are not as good as routine infection, and these parts again will be talked by the future speakers on how to go about assessing the various protocols and identifying the source of infection. I think I'll stop here and open for discussion. Thanks. Thank you.
Thank you, Saravanan. And there is one question somebody asked: when will you start oral steroid? Do we have to wait for the KOH report at least to make sure that it is not fungal and then to start, or should we have to go?
Clinically, if you're not suspecting fungal, you can start early on. So even from the first day itself, you can start especially if the infection is not very severe. But if you're suspecting fungus, then it's better to hold back both topical as well as oral till you get a confirmation, because fungus, starting steroids can totally alter the outcome. Where there is no corneal involvement and where you're not suspecting fungus, probably you can start even from the first day itself, right away.
And will you go for intravitreal steroid in such situation?
First sitting, at least in Coimbatore, we don't give intravitreal steroid in the first sitting. But when the patient is responding, when you are giving the second injection or third injections, we add steroids, especially we are happy with the progression.
Okay, we have some more questions I think Saravnan already has most of them answered, like, hour by hour, if the cases are getting worse, what we have to do, how to prevent from panophthalmitis.
So panophthalmitis, sometimes the orbital inflammatory component can persist in spite of eye improving. So in that cases, giving intravenous decadron helps to counter the orbital signs. Once you are sure that the intraocular infection is getting controlled, the intraocular infection is not also is not getting controlled, then you have to look at multiple drug resistance or wrong diagnosis. Sometimes can be a unusual organism which is not responding to your drug. So then you have to go about to identify the culture and see what drug is going to. So in these cases, you can go for the colistin, imipenem, and polymyxin B, which can be given intravenous also.
Thank you. Dr.
Yes, madam.
Chandrasekhar sir, would you like to add?
No, madam. I think everything has been clearly told. We'll move on to the next talk. Now it is my pleasure and honor to invite Dr. Revati, madam. Dr. R. Revati is the head of cornea services at Aravind Eye Hospital, Coimbatore. She is one of the senior most surgeons in Aravind Eye Care system. With her vast experience, she'll be able to give us a lot of input about the perioperative prophylaxis. Over to you, madam.
Thank you, sir. Thank you, sir. And this talk will be what we routinely do, not only for cluster, regularly what we have to do to prevent any kind of infections after cataract. And this, already Dr. Dear sir, as well as Saravnan already mentioned what is the difference between sporadic endophthalmitis and cluster. But in case of cluster, as already mentioned, usually the source of infection in any endophthalmitis can be from the patient or from the hospital or from the healthcare personnel. And in case of cluster, we can rule out the first incident from the patient. So the next two, the hospital as well as the healthcare provider, we have to concentrate on that. So when as a prevention, all the source can be anything, whatever supply we use, consumable we use during the surgery, starting from, as mentioned, even a topical anesthetic drop. From there, anything it can be, even our tap water, as in the case of acanthamoeba that was suspected to be the culprit. So anything can be the source. So we have to keep an eye on all these things, and you have to maintain a very strict and standardized protocol in using all these things. Let us start with from the patient. Concentrate on the patient's periocular area, especially if the lid margins, because MGD is a very common association in elderly people who come with cataract. And especially nowadays, when we plan for a same-day surgery and all, it's better to concentrate on this area and look at, and if it is significant, better to postpone the surgery, prepare the ocular surface and lid margin with the regular therapy like systemic doxy or azithromycin, hot fermentation, or even nowadays recent gadgets are there to go for instant massage and removal of the material inside. And this we have to do, and then take up the patient for surgery. In case of sometimes we come across something like pustule, they used to call, but usually they are some cyst or chalazion, a burst chalazion with a granuloma inside. They are not infective conditions as such. Either we can just ignore them and go ahead with the surgery, or to be on the safer side, we can go and meddle them, like we can scrape them off or open them up. But if we do something like that, always wait for 3 days, treat them with antibiotic, and then take them up for surgery. Don't do it at the same sitting. And it's very important to do either Roplas or syringing. Syringing is not that much routinely done nowadays, but the just pressure on the lacrimal sac area and looking for any regurgitation is a very, very important, simple test which has to be done by the doctors. And treating any ocular surface problem like allergy, dry eyes, and especially patients who are on topical medications for a long time, like in glaucoma and all, we have to pay attention to the ocular surface, and we have to treat them and control the condition, and then go for surgery. And also we have to address the lid problems also. And in case of culture, conjunctival culture should we have to do preoperatively as a routine. As a routine nowadays, it's not being done. But as I said, patients on some topical medication for a longer time or who are having some periocular or ocular surface problem, it's better to do. Or also in one-eyed or uncontrolled diabetics and all these patients, better to do a conjunctival culture, at least to be on the like a protection for you later if there is any untoward incident occurs, and then go for surgical intervention. And also it's important to attend their systemic problems. A good glycemic control is very, very important. It's not that on the day of surgery, the blood sugar level is whether it is controlled or not, because that alone is not enough. We have to go for HbA1c and also advise the patient throughout the healing time also, their sugar level should be controlled. And in case of patients with COPD and other allergies or asthma, whether they are on some steroids or any immune modulators, then we have to consult with their treating person, whether they can be withhold or whether they can be altered, that we have to see. And in case of atopy, we have to be very careful. Atopic dermatitis, these patients are often prone for fungal infections. So it's better to get a dermatology clearance just before taking them up for surgery. And patients with emaciated look, always be careful, especially when they come in camp, because these patients are more likely to go for nocardial infections. We don't know from where it is coming. Is it from the lungs? We don't know. Is it endogenous? We don't know, but they are very prone for nocardial infection. And any other source of nidus or of infection like a dental problem and other things also, we have to look for in the patient. And the coming to, if the person is an individual surgeon, of course, it's very important to meticulously attend their regular protocol, sterilization protocol, as well as the documentation of all the sterilization consumables we use. Dr. Adyar already pointed out, and Dr. Shivakumar will be talking about it in detail. And it's also important to maintain a log like this, which table, which surgeon, how many case it is, all these things. And if you are using EMR, of course, the timeout call will help in this. So meticulous documentation of all the steps in surgery is very, very, very important to find out the root cause later. And the preoperative eye preparation, topical antibiotics, whether they have to be used or not is still a question. And many people, even ACRS survey, mostly 80% of them, they would like to use it, because to be on the safer side, the people like to use, but it should be started at least 3 days before. That's what they are telling. But one thing we have to keep in mind, it may reduce the colonies, but it will not alter the normal flora altogether. And also whether to use unnecessarily to prevent any resistant strain development, that also we have to keep in mind. So the most recommended one is the iodine preparation, 10% for skin and 5% for the conjunctival cul-de-sac, which has to be the contact period is more important than the concentration. At least for 3 minutes, it should be in contact with the conjunctival sac. So it's better in our camps and all, when we do large number, we prepare the patient when they are waiting outside once and again on the table and then apply, so that the contact time will be maintained toward the time. And there is some reports, especially from Japan, we can use it as a surface irrigation so that it will reduce the positivity of the ocular surface pathogen is there, but it's a highly irritant drug also. We have to think about the surface toxicity, especially corneal toxicity also. So intraoperatively, as mentioned already, the instruments has to be properly laid out. The used instrument and the unused instruments have to be separately kept, and the tips should not be touched. And the preparation of the eyelash clipping is nowadays not being used, but we have to use a proper draping has to be done, which is covering the lashes very well. And it's better to go for disposable drapes rather than cloth drapes, which are being reused. Then the section, is it the wound, whether a particular type of wound is more prone for infection? It is not very clear. Generally, clear corneal incisions are more documented to be more prone for infection because they are more exposed. Not only exposed to the reason we will see soon in the next few slides, But whether it is a superior one or a temporal one, it has both has advantage as well as disadvantage. More than the location, whether we have achieved a tight wound, a leak-proof wound is very, very important. So especially a clear corneal wound, if it is not really even a tight wound, sometimes has been shown to there will be ingress of fluid from the cul-de-sac, especially if there is the blinking movement and the negative pressure is being created. And that's why it's very important to make sure that there is no leak at all, or if you are in even a slightest doubt, better to go for suturing. And it is proven that a sutured wound, you can reduce the chance for infection greatly than in an unsutured wound. And so it's always, we have to hydrate nominally only. Should not be too much hydration, should not be done. And if you are in doubt, go ahead with suturing, don't hesitate for that. And then during the surgery, if there is a complication, especially the lens diaphragm is violated, the posterior capsule is violated, anterior vitreous face is violated, then the chance for infection is almost 8 to 10 fold. So it's better to, in these cases, approach differently. Better to add an oral antibiotic or systemic antibiotic on the safer side. How much it will help, we don't know, but still it's better to add, and also topical, more frequent application, and closely follow them up, admit them and closely follow them up. That's very, very important. And in case of IOL, an injectable IOL is always preferred, because rather than an inserting IOL, which will, so that it will not touch anywhere on the ocular surface. And the intracameral antibiotic, the ESCR, after the ESCRS recommendation, this has become a norm nowadays. Initially, they recommend cefuroxime, but the problem, mixing at that the compounding is a very important thing, because any dilution error can lead on to severe problems like foveal necrosis and all. It has been reported. And also cefuroxime being a penicillin group, like it can lead on to anaphylactic shock also. So moxifloxacin found to be a more safer drug. And also if it is available in a single-use syringe, single dose, already pre-filled syringe, it is more ideal, and it can be given at the end of surgery, and then the wound can be sealed. And external sealing, we can, this is my favorite technique. I used to paint it with a viscoelastic later, and also at the end also I used to put a drop of diluted 1% iodine. So the sealing wound is very important, and also PA at the end. And eye patching, better to go for eye patching at least for 4 hours. It has to be kept. And post-operative antibiotic, we have to be very careful, because in an uneventful surgery without any problem, optimally it should be used. It should not be used for a longer time to prevent any antibiotic resistance also. And post-operatively, nowadays patients are more would like to go back to their routine as soon as possible. Of course, we have to consider that, but at the same time, make sure that they understand that this is a surgery, and also there should be a balance in their activities post-operatively till the wound heals at least. As you know, the corneal wound, a clear corneal wound will take anywhere between 8 to 12 weeks to heal properly. That we have to keep in mind. So in conclusion, approach the patient as a whole, not only the eye, as a whole, systemic problems also, many more attention to the periocular area. Monitor, I mean, it's a routine. If in our institute, each surgeon, before starting the surgery, go and look at that logbook, whether the sister has entered everything. And then though the CSST team will do it routinely, we have to see and countersign. So make sure that you are sticking on to the protocol as well as the proper documentation, and then proper patient preparation. And the intracameral antibiotic also found to be really useful, and Dr. Haripriya can give first-hand information about it. Enhance the antibiotic prophylaxis whenever there is a complicated surgery. Thank you.
Thank you so much, madam, for an elaborative talk, but you made it very short and nice. I'd like to request Dr. Haripriya Arvind to give her comments on the perioperative prophylaxis. Over to you, madam.
Thank you, madam. I think it was a very exhaustive talk, and gives a lot of aspects on prophylaxis and what care one should take in terms of patient preparation. So as madam rightly pointed out, I think the only technique where we have level 1 evidence to prevent endophthalmitis is use of povidone iodine. topical antibiotics are used widely, but the evidence is not much. So, but it's the most commonly used. Like Madam said, the ASC had a survey more than 90% use pre-op and 97% use it post-op. The other thing which is gaining more interest these days is intracameral antibiotic, and moxifloxacin is preferred because earlier it was vancomycin in the US and some other countries, and in Europe it was cefuroxime. Because of the risk of anaphylaxis, more people are shifting to moxifloxacin. And the efficacy, as you know, as we saw with the various, most of these studies are retrospective, but we have very strong evidence in literature from many large retrospective studies that this reduces endophthalmitis by about 3 to 4 times. So that's why we would suggest using this, at least, if not in all patients, at least in high-risk eyes. Eyes which have a complication like a posterocapsule tear, vitreous loss, eyes which are going in for secondary IOL implantation, combined vitrectomy and cataract surgeries, sterile fixated lenses. So these eyes have a 10 to 20 times higher risk of endophthalmitis. So at least in these eyes, I think it is recommended to use intracameral antibiotic, even if one does not want to use it in all patients routinely.
Thank you, Madam, for your comments. Madam, over to you, Madam. Dr. Revati, Madam.
Yes, thank you, Dr. Haripriya. Now I invite
Dr. Shivkumar.
Yeah, one second. Dr. Shivkumar, I invite our cataract chief in Trinelveli, Arvind. And he also, like, especially along with Dr. Haripriya and Dr. RDR team, is very instrumental in developing many the protocols, operating room protocols, and is well versed in this. And again, we are insisting following these protocols and documentation as a routine is very, very, very important. Even in the case of cluster endophthalmitis, this is which is going to help us a lot. Dr. Shivkumar.
I hope that I am audible and my slides are visible.
Yes, Shivkumar.
Thank you very much, Madam, and thanks a lot to the organizers and the panelists and the chairpersons for giving me this opportunity to talk about operating room protocols and documentation. Nowhere else is this dictum more appropriate than in facing a case of endophthalmitis. Prevention is always better than cure. And we know that prevention of endophthalmitis starts with a good OT infrastructure according to specifications laid down by various organizations, and also the HVAC, heating, ventilation, and air conditioning specifications and air handling units. So these specifications also help in preventing. But more important is a thorough cleaning and disinfection in the operation theater. And the most important is a meticulous cleaning and sterilization of the instruments. So we know that the prevention of infection is based on 3 pillars of cleaning, disinfection, and sterilization, where cleaning is the removal of dust and foreign particles from the surfaces of the floor, fixtures surrounding the surgical area, and the disinfection is removal of most of the pathogenic microorganisms, and sterilization is removal of all microorganisms, including the spores. So we come first to the cleaning and disinfection protocols, and we know that this is to prevent the contamination of the surgical field. And we know that the high-touch areas in the operation theater, they should be cleaned more frequently by the right person. That is the person who is well trained to do this at the right intervals, depending upon whether they are high-touch or low-touch areas, and with the right material. The commonly used disinfectants are contain benzalkonium chloride or sodium hypochlorite, and the intervals can be daily, weekly, or monthly, depending upon the status of the area. So the daily cleaning is usually done for the OT floors, walls, all fixtures and equipment. And having said this, we need to keep in mind that only about 1% of the microorganisms on the floor and on the walls are pathogenic. The weekly cleaning involves all these structures, the floor, walls, and fixtures, and also the ceiling and AC filters. And the monthly cleaning is for the less accessible places, the nooks, corners, and the RO water tank and the AHU filters. Fumigation is now a fading practice, especially with formaldehyde. There are alternative solutions available like Emodil, Bacillus, and Bicron. But then ideally it is indicated only if a new operating room is commissioned after 3 consecutive negative culture reports, or if you are starting an operating room after construction or repairs. And if we have an AHU with a HEPA filter, which is kept on for 24 hours, with the AC not functioning during the time that surgery is not on. But if the AHU is on for 24 hours in the blower mode, no fumigation is needed. Coming to the cleaning and sterilization of instruments, which is probably the most important part for prevention of endophthalmitis. It is imperative because these instruments come in direct contact with the eye, and special attention is to be given to the cannulated instruments. And these instruments which have been used should not be allowed to dry, because it is difficult to remove the organic material and the debris which stick to these instruments. So the preliminary cleaning should be done with RO water, and then should be subjected to ultrasound cleaning for 3 minutes, which helps to dislodge the debris and the organic material. And then a sequential cleaning is done in 3 basins of RO water. And this water is collected through a 0.2 micron filter. And the first basin, a soft toothbrush is used to meticulously remove all the debris, and then 2 more sequential rinsings are done. Equally important is the drying of the instruments, especially the cannulated ones, because the damp or water-containing cannulae do not get autoclaved or sterilized properly. Also important is the proper packing of these instruments for autoclaving or for chemical sterilization, because if they are too closely or tightly packed, this may not happen properly. As far as cannulated instruments are concerned, the Simpo is to be flushed with 10 cc 5 times, hydrocannula 5 cc twice. The phaco tips and sleeves and IA tips 10 cc 5 times. Phaco and IA handpieces should be flushed from both the irrigation as well as the aspiration ports with warm RO water 20 cc 10 times, and an equal amount with air so that they can dry. The sterilization of instruments should be done, if possible, by a dedicated CSSD team or with well-trained staff, and they should follow the validation protocol. There should be unidirectional flow to avoid any mishap or mix-up of material, and it should be from the unclean to the clean to the sterile area. The sterile items should be stored properly, and there should be no mix-up. There should be a strong recall policy, and if there is any doubt, it should be considered as unsterile. Then coming to the sterilization validation, which is the most important documentation and oral surveillance protocol, we use chemical indicators. The class 1 indicators are used for steam autoclave as well as for PTO. And this is a 3-line tape with the initials of the operator, the load number, the autoclave, and the date of sterilization and the date of validity. And this is placed in every set, every bin, every load, and at various levels in the linen bundles. The class 5 indicator steady gauge, which we saw, is placed in every load over the bins in every cycle, and in every bin at the top, middle, and bottom to ensure proper sterilization throughout the bin. And class 2 indicators should be there for ideally every load, the Bowie-Dick test as it is called, and at least once a week for each autoclave so that we know that it is functioning well. Also for the functioning, we have the biological indicators. For the steam autoclave, we have the Geobacillus stereothermophilus and Etiobacillus atrophius, and this is done once a week. The OT microbiological surveillance may probably be dealt with later in another talk, but the OT environment should be checked once a month, RO water twice in a month, and irrigating solutions and viscoelastic before we start using the new batch. Now coming to documentation, which is the most important aspect when we face an endophthalmitis or a cluster endophthalmitis, because documentation will help us in tracking back to find out any deficiency or lapse in the sterilization or the cleaning process. So this is a documentation for cleaning and disinfection. We can see that a register is maintained with the time where the cleaning has been done in the different areas, who has done the cleaning, and then the end of the day cleaning of the entire OT. And it is countersigned by the sister who is supervising them, as well as the CSSD sister in charge. Now, this is a checklist for all the OTs and the surrounding areas and the areas outside the OT. This checklist helps in avoiding the missing out of any of the fixtures or areas. And this is for 5 days of the week, and another checklist for the Sunday with additional areas like the AC room and the dress changing room and other rooms. So these checklists help to make the cleaning thorough, and it is countersigned by the supervisor. This is the schedule for the AHU filter cleaning schedule and the raw water tank cleaning schedule, which is done once a month and countersigned by the infection control in charge. Now, documentation of sterilization validation is probably the most important when it comes to finding out deficiency in sterilization. So here is the printout from the automated autoclave, and you can see that the different cycles have been marked out. And the operator has found out if the minimal temperature is above 121, and if the fluctuation between the highest and the lowest temperature is within 2 degrees centigrade. It is signed by the operator and countersigned by the CSSD in charge. This is a register containing the steam sterilization monitoring. This is the steady gauge from each of the cycles from each of the autoclaves, and this is from the each of the cycle from the in-between sterilization in the high-speed autoclave. Similar 3-line tapes from each of these cycles, but this also contains the time of which the cycle, the timing of the cycle, as well as the person who has carried out the loading and the unloading. And this is another register again with a 3-line tape, and this shows all the bins from which OT which has been loaded in that particular cycle, and this is for each of the autoclaves. So these records help in tracking back as to which load or which cycle could have been defective. Now this is a similar record for the ETO sterilization, where we have the entire ETO cycle as well as the indicators that the sterilization has been completed and what are the materials which have been sterilized in that particular cycle. A similar manual record kept as to which material from which OT has gone in for that particular cycle. And this is a register which is maintained of sterile packs which have been removed from circulation at least 1 week from the expiry of sterilization. So it usually is valid for 1 month, and this is taken out 1 week prior to that 1 month, so that we don't use expired material. Now, this is one very important documentation maintained by every operation theater, where the 3-line indicators of every bin that is used in that OT on that day has been stuck, and also the steady gauge class 5 indicator and the ETO indicator. And a close-up will show that the temperature and humidity has also been noted. And this is the list of the consumables or the injections, intracameral injections, which will be used on that day, along with the batch number. So it is easy to trace this back. This is a 3-line indicator of every bin during the in-between sterilization from the high-speed autoclave. And this is the most important documentation. On the patient's case sheet, the 3-line indicator from that particular set is attached, so that we can always trace back based on the name of the operator, the autoclave, the load number, and the theater. So, and this is a very important documentation, which is called the recall register. And any lamps in sterilization or any deficiency is noted, and the corrective action is noted. And this is countersigned by the infection control in charge and is closely monitored. This is the result of the Bovidec test, which is done on a weekly basis for each of the autoclaves. And this is a record which is maintained for the biological indicators from each of the autoclaves, ETO, as well as from the other autoclaves. And this is promptly countersigned by this infection control in charge. Finally, the documentation of surveillance, we have the OT culture reports every month, and if there is any discrepancy, any deficiency, then there is this highlighted, and comments are made by the infection control in charge on real-time basis so that corrections can be done. This is the water culture report, which is taken once in 15 days, and this again is countersigned by the infection control in charge. And this is the RO water analysis, chemical analysis, which can be done at a lesser frequency, but we do it at once a month. This is a record of the pH values and the culture report of various consumables when a new batch is started for BSS and for viscoelastics. And this is also kept and countersigned by the infection control in charge. To conclude, cluster endophthalmitis can be prevented by adequate training regarding these protocols and making sure that these protocols are strictly adhered to, by monitoring that adherence and having evidence-based revision of protocols whenever it is needed, and having a meticulous documentation so that we can go back and find out any deficiencies. Thank you very much.
Thank you, Dr. Sivakumar. It's really a very excellent and a detailed this one documentation and what has to be done. And I had a question during one of such similar session in on AOS when the same talk was given. One person asked, like, it may be possible for you people in institute to do all this elaborate documentation and surveillance. And what about a single surgeon or a small hospital? I request Dr. RDR sir to give a comment about answer for this. Also, I request Dr. Nirmal to give, because being a quality person, his comments about Dr. Sivakumar's topic. RDR sir?
Yeah. Thanks, Revati. I mean, there is no question about the documentation. I think we need to do this documentation. It's very important. I mean, while the documentation part can be delegated to the nursing staff, who can do it, nursing staff and the technicians. But equally important is also monitoring of the documentation. So both are equally important. The monitoring has to be done by the surgeon or the surgical team. So, I mean, both the documentation plus the monitoring by the next level is very important. If we have to make sure that it's all about developing a culture. So only when you have this documentation monitoring, the staff also understand the seriousness. I think which is very important for a long-term sustainability of any private practice, especially in an institution. Some of the instances, probably the institute may be able to withstand, but it's very difficult for a private practitioner. So it's really important for a private practitioners to be even meticulously maintain this. There are many people who do it in practice. Yeah, that's the truth. I'll probably ask Nirmal can give his opinion.
Thank you, sir. Thank you, madam, and thank AOS and Orolab for this opportunity. And Dr. Sivakumar has really highlighted the important aspect of sterilization protocols and documentation, which is the cornerstone of preventing cluster endophthalmitis. As you rightly said, documentation is very important because a good documentation helps you, the doctor, and the poor documentation helps the patient's lawyer. So if you really want to help the lawyer, you can miss some documentation, or you can give this or part to somebody who will not do a good job. Whether single specialty, whether institutional practice or individual practice, it makes sense to document things because even for smaller practices, it's easier because their volumes are less and they can train people who stay with them for a long time. And these are repetitive documentations. So you can get the help of technology to repeat it. And it's also, since it's a repetitive job, most of us do only one type of surgery or maybe a maximum 2 or 3 types of surgery. And many of these are similar data sets. So you can really train your optometrist or technician to document them. So documentation, whether manual or EMR, so it all depends on the culture, as rightly said by Dr. Adya, the culture of the practice. And particularly with healthcare attacks increasing and the CPA Act really a lot of cases being filed. So it's very important that we streamline our practices. So whatever you do, you document, and whatever changes in that particular case, the doctor should come and write it down. So that really helps. So documentation with technology is easier now with the apps coming up. So it's easy to adopt, say EMR in a, previously we need to have desktop or train people. Now it is all app based and cloud based, so it's easy. So we have to adopt technology to help us in documentation also. These are some ways we can improve our documentation. Thank you, madam.
Thank you, doctor. I invite the Orolab to show their a 1-minute video about the endophthalmitis kit as well as the intracameral injection.
Thank you so much, Aurora, for demonstrating two important tools. One is the prevention, Moxiflox and the e-kit, which can be used by anyone. They will be wonderful tools, and the delay in transferring patients, sending patients can be avoided, which can save many eyes. Now, I would like to invite Dr. Lalita Prajanna to talk on root cause analysis and microbiological surveillance. Dr. Lalita Prajanna is a rare combination of an ophthalmologist and microbiologist, one of the very few in the country and probably in the world. She has vast experience in managing infection cases, endophthalmitis in workup, and she is also lead for NABH, and that way she's trying to implement various HIC activities across the 14 hospitals of Aravind Eye Care System. Over to you, madam.
Thank you, sir, and good evening to everyone. So I'll just start my talk. So my topic is the root cause analysis and microbiological surveillance in an event of cluster endophthalmitis. So we've heard all the eminent speakers before elaborating on how to prevent it and how to manage it and how to have the documentation and everything. But when an actual event happens, when anybody is faced with an outbreak, everybody is so anxious to know what actually caused it, and then to stop it as quickly as possible so that we can prevent further cases from happening. So that's what I'm going to be talking about. So the first most important aspect to be considered is the time. So if an outbreak is suspected, an outbreak need not be like 5 cases, 10 cases. It should be anything which is more than what is routinely seen. So that should be the definition everybody remembers. Even if you're going to get one case more than what you normally see, 1 or 2 cases within a certain time period, you should have a suspicion that it could be a cluster, and immediate action must be taken so that we can implement a root cause as early as possible. Because we know the faster we do, if we delay it more, people will tend to forget the details, and they would forget the protocols which they followed, and then we might also lose a lot of important consumables that need to be tested. So all this, considering the time is of essence here, and also time should be given to the investigation team to gather all the information that is needed. And all this is very important to prevent any further cases from coming or even preventing future outbreaks. And one point which I would really like to emphasize here is, whoever is going as an investigating team or whoever is doing a root cause analysis in your own hospital, or you've been asked to come to some other hospital, it is be very important if they have some basic knowledge of ophthalmologist. Of course, everybody knows, but anybody else in the team, especially the microbiologist, if they have a knowledge of what is the protocol that's commonly followed, that will be very easy to start doing a root cause analysis. And there is this publication in IJO by Desai et al., which is very nicely, she has put some recommendations for investigating cluster endophthalmitis. So if anybody who really wants to have more in-depth knowledge can read this paper. So as I said, if a team is constituted, each one should be very aware of what is their role and start doing according to what is given to them. Now coming to the role of the microbiologist per se, as I mentioned, if the microbiologist is already actively involved in the theatre activities, the ophthalmic theatre activities, the CSSD activities, and they already go for a routine audit, or they have a HIC, they're part of the HIC team, then they might be already having a checklist, to start going and doing an audit. And first thing what they should be doing, or we should be doing, is start a step-by-step analysis of all the incident which actually happened. How many cases, who operated, the date, and all those things. And then go through all the various protocols. And then finally start the sample collection. So this is before I go into my actual root cause analysis talk, I just wanted to share this experience which we had, which both Dr. Adya sir and Saravanan actually mentioned this case scenario which happened to us. So this was very interesting. As sir mentioned, a few cases started coming which was operated elsewhere with just a wound infiltrate. Some cases had some vitritis, and actually no case had a very frank bad endophthalmitis. And those cases grew this gram-negative bacteria both from the wound infiltrate and from the vitreous. And then as sir actually showed this slide, as you can see, an interesting thing is the day of presentation. So the first case only presented only after 12 days. So long time period that shows itself this organism is very slow growing organism, and it wasn't very virulent also. So after 5 or 6 cases, then we were invited to that hospital, and then we started doing a thorough investigation, and we took the samples from all the relevant areas, and whatever is possible, we started collecting the samples. And normally when we go, especially after such a long 10 days, nearly for 2 weeks have been passed, very difficult to find the source of infection. But in this scenario, when we did a microbiological investigation, so as is routine for us, we just went about systematically collecting samples from wherever areas, even though they may not be directly related to the actual endophthalmitis, we just started collecting from everything because we didn't know, what to collect or what to leave out and what we would be missing. So as you see, there were some growths which were actually not related to the actual endophthalmitis patients. So we also started seeing from the patient's eye drops and from the eye drops which were there in the OT also. And then we saw this one eye drop which topical anesthesia which grew this organism Burkholderia. So then we went and purchased and got some more of this same batch of this company, and that also grew this organism. Unused sterile pack also grew the same organism. And then we speciated it and we did a box PCR to see for the clonal relationship to really prove that this is the same organism which grew from the patient's eye and also which was isolated from the sterile bottle. So this is the kind of scenario which most of the people, the doctors might be facing, and this is where I think Mr. Krishna Kumar's talk will be adding some light into such a kind of scenario. So now coming to the actual starting the root cause analysis. So going by the published literature, we can see that each and every item that goes into the eye has at one point of the time been a culprit in causing cluster endophthalmitis. So because of the either the break in sterility or because of the storage conditions or for some reason it's already a pre-sterilized consumable could become contaminated, or some break in the protocol could lead to this thing. And then also, even if it's not the actual consumables, even other things like improperly maintained autoclave instruments, sometimes autoclave is not serviced properly, poor operating room hygiene, contamination of ventilation system, although these might not be directly related. We see very, very few reports of actual ventilation system causing cluster endophthalmitis. So the organism profile, if you see, so this is very important for us to have a clue. So if the vitreous sample is going to start growing such kind of profile, then immediately it should external contamination should be suspected, because none of these organisms are actually a normal flora. They're all part of growing in the environment, water contamination, soil flora. Especially Pseudomonas sootzeri, nowadays we are seeing a lot of Pseudomonas sootzeri infection. So this is not as virulent as Pseudomonas aeruginosa. So it's much more slow growing, and actually the outcome is much better than aeruginosa. So recently also in a nearby a place we saw 2 outbreaks of this. So when we're going to start a microbiological surveillance in a scenario of an outbreak, I'm not talking about a routine surveillance, it's very important that we have a plan on where to take the swab. So either we collect too many samples or too many swabs are collected will give a confusing picture, and then finally the interpretation might become very difficult, because obviously if you're going to collect too many swabs, something is going to grow. Definitely the place is not going to be very sterile. So whether that is going to be implicated or not, all these are very sensitive issues and emotional issues also. So much of it's the law is involved, the media is involved, patients are involved. So this interpretation of culture results should be with the correlation, and clinical knowledge is very important for us to give the report. So the role and the responsibility of the investigative team in analyzing. So we can, as I mentioned, we can start going by the checklist, and a checklist can have all these questions that need to be answered. So if you go systematically, this might give you a clue as where the problem could have started coming. Like in that instance, when I was mentioning that outbreak of Burkholderia and where the anesthetic eye drop was involved, the surgeon had a practice of putting the eye drop on top of the blade just before entering. So that is why that port of entry had a lot of infection there. Again, this data, this table is got from this paper. So people can go back and refer this paper if you want to create a checklist. And then also the culturing of potential sources of infection. As I was mentioning, we also actually whenever we are called to do anything, we go about testing all this. But again, caution should be taken whether you really want to go and culture all these areas. But definitely what should be cultured is the consumables if it is available. And then finally, after doing all the culturing, getting the microbiology report, it is better to first start giving a preliminary report. So first initial report can be given to the hospital or given to the concerned authorities, whoever is involved in that, about what is our plan, what materials we've gathered, and what is our plan for analysis. Then after the microbiology report is finished and completed and all the analysis is done, a final report should be given, and it should be properly written, because the report is what is going to be really important, in handing over to whoever is responsible, all the health authorities or the lawyers or anybody. And if the possible source is identified with the strong evidence, that can definitely be mentioned. And suppose if there is any recommendation for improvement in the theatre, that should also be mentioned. And if any remedial measures to be taken also should be mentioned. So I just want to conclude this talk by putting a slide on, we've spoken about root cause analysis, but root cause analysis becomes very, very much more easier if preventive measures are already in place. So how Dr. Sivakumar mentioned in detail and Dr. Raiviti mentioned the preoperative prophylaxis, if all that is already there, so first, most important is the responsibility of the doctors. Many places, maybe the surgeon just comes and operates and leaves, and they might not be actually involved in the day-to-day activities. So I was just thinking like how we do a code red mock drill or a mock drill for a code blue. Even if a code like a mock drill is done for a cluster, and if you're already ready, prepared, like how we are going to face in case you're going to meet with a cluster, then that makes it so easy if and ever you, if anybody is faced with an outbreak of infection. So if the doctors get themselves oriented to what the protocols, and if they take part in the OT CSSD meetings, if they also check all the registers, make sure all the manpower is adequate, training is adequate, and all the instruments are serviced properly, and if there's any issues happened, what action was taken, and a periodic audit is very, very important in the operation theatre. And so finally, we know that it's very difficult to identify the cause in most of the situation. Proper plan for collecting the sample, a lot of responsibilities for the investigative team, especially when reporting contamination in sterile products. So the lab must make sure that they have all the measures in place to do an analysis for testing of a sterile product. And so finally, to conclude, we all know that we want for the best for the safety of the patients is our priority. But in spite of all protocols being followed, outbreaks tend to happen because of multiple factors. And most important is we should try not to compromise on the quality of the consumables and which is going to be used. And proper documentation, as has been mentioned by each and every speaker till now, is going to be the most important take-home message from this seminar. And a lot of references are available right now, right from AAO's task force reference, Royal College, the NPCB guidelines is also available, and the ECRS. So it is very good if we can go through all this and equip ourselves with more knowledge. Thank you. So that's my.
Thank you, Dr. Lalita. It's really very, very helpful talk. And I welcome Dr. Namrata Sharma and Dr. Rajesh Sinha, who joined us at this moment. And I would like to call Dr. Nirmal to give some comments about Dr. Lalita's talk. And also I would like Dr. Ardia to add any more points like about this talk.
Madam, welcome Dr. Namrata and Dr. Rajesh. Thank you for joining us.
Thank you.
And you come at the right moment. And thank you, Dr. Lalita, for covering it so nicely, all the salient features and important points have been already said. And one thing I would suggest is to investigate every case of endophthalmitis and TAS. That really helps. Not only 2 or 3 cases, but also even single case have to be reported, documented, and root cause analysis done. So that will actually help even the small practitioners to understand how a root cause analysis can be done. And second thing is having a checklist. So developing a checklist is easy. I think AOS can help in this regard, having a standardized checklist. So that since we have the infection control guidelines given by AOS with the help with NPCB, we can also develop a standardized checklist in case there is an incident of TAS or endophthalmitis reported, how to go about it. And before suggesting something, maybe the root cause analysis team or the team which is formed to investigate it should visit all areas of OT. That includes the entire floor as well as the terrace or the roof where the water tanks are situated. So that is probably one key area where we have to focus. I also mention about this incident where I was involved in the investigation. We had 4 cases of wound infiltration, 2nd or 3rd week after cataract surgeries. The first case was normal, but the 2nd and 3rd case or consequent cases were involved with wound infiltration. So we investigated all the consumables and also the practice of the hospital. This was 10 years back. At that time, people used to reuse the blades. And the blades given by as a physician sample after attending the conferences. So the first case got escaped, but the 2nd and subsequent cases got infiltrated. Only the wound infiltration with the anterior chamber reaction. And we investigated and found that they put the blades in the glutaraldehyde. So that tend to stay in the glutaraldehyde, and they never used to change glutaraldehyde for a long time. So they used to change it every month because of low volume center. Then we found that the glutaraldehyde grew Bacillus cereus. So it's a very common in organism, but it's very uncommon to produce endophthalmitis. It was a low virulent organism. So that's the reason why they escaped for the first 2 weeks and later on had. So you have to really avoid chemical sterilization of any kind. That's one of the reasons even in standards we say avoid all types of chemical sterilization, including ETO for intraocular surgeries. So well done, Dr. Lalita. You have covered almost all the points. And most of the microbiological surveillance have to be done during commissioning and recommissioning of OT. Even if you're going to stop operating for 2 or 3 weeks, better to have a microbiological surveillance while recommissioning the theater. That is more important than the regular microbiological surveillance. Maybe one checklist about the microbiological surveillance instead of being routinely done every month. So even for a low volume center, it is really costly. So it has to be dependent on the number of cases are operated or the scope of services. So it has to be customized to the need of the hospital rather than giving a single point, say, every month or every week, because the government people tend to look only at this frequency rather than the number of cases or the complexity of cases being operated in the data centers. So these are some of the points I want to share here. Thank you so much.
Dear sir.
Thanks, Revati. I mean, it was very well covered by Dr. Lalita. I mean, Sena, if you want to really do a thorough root cause analysis and to find where this organism should have come, I think it starts with making sure that we do a good vitreous tap or aqueous tap to ensure that we are able to culture that organism. So getting that specimen, making sure that we culture that organism is very important. The second point, as Dr. Lalita shared one example, how one particular instance was analyzed, because I was also involved along with that. The first day when we went to that particular hospital and the OT when we did the analysis. Now, if there are the organisms grew in several samples, the water, the operating room, many places it grew, but none of them matched with the organism that we found from the eye or from the vitreous or from the anterior chamber. So I mean, we knew that even though we had cultured the organism from different locations, they are not the cause. Then we went back and looked at many things, every consumable that was used in the operating room for those patients. That's where we found the organism from the particular unopened anesthetic eye drop bottle. I mean, otherwise we could have, if we had missed that, if we had not gone back trying to look into every source, we could have missed the source in the particular series of cases. So, I mean, it starts from right from the beginning, right from the way you take the specimen, culture it, to making sure that every consumable is seen. So that is where the documentation which Dr. Sivakumar showed becomes very important. If you don't have the documentation, then the microbiologists won't be able to help. So having this documentation, monitoring that, making sure that what is documented is what is actually used, all that becomes very important if you want to analyze such cases. Yeah. So that's all the brief comments. Thank you.
Sir, another question, especially to Dr. Namrata and Rajesh also. What is your recommendation, like whether the consumables after being used, like irrigating solutions and other things, the leftovers, should we have to keep them routinely, especially in large volume centers, and also how long? Because as Dr. Lalita pointed out, that if they are available, they also has to be subjected for surveillance. And this is being recommended theoretically, but is it possible or is it should be done? I would like to know.
Ideally, I think it should be done, but I really don't think that it is being done at all centers, at least for a prolonged period of time. And I think there is another element which we've also discussed before, even at the level of AIOS, and Dr. RDR sir and Dr. Nirmal Frederick know about it already, and so does Dr. Chandrasekhar also. That what about the contaminants in the consumables? I mean, it is okay and it is all right that the surgeon does have a responsibility whenever there is any endophthalmitis which occurs, whether it's cluster endophthalmitis or otherwise. But what about the consumables like irrigating solution or viscoelastics, which may be harboring the microorganisms, and the infection may have come from there? So I think when we discussed even in our AIOS meeting, and also I discussed with Dr. Chandrasekhar, we cannot get a complete relief on it because we cannot be absolved of our responsibility as far as the surgeries are concerned. But a partial relief can be obtained that these manufacturing companies or these partners who are also involved in the entire cycle of surgeries and outcome of surgery should also be made responsible at least for something. So I think that is something that we are looking at as far as the AIOS is concerned. But I agree with you that ideally they should all be kept. I don't know, in our institute, I don't think we are keeping it for too long. The consumables, most of them generally are discarded. I don't know about the policy of Arvind or the policy of other hospitals and institutes.
I guess practically it is not possible to preserve it for very long and send it for culture every time. But I guess maybe randomly, once in a while, if we can keep doing it for, separate batches, maybe we'll be in a position to monitor it. That's what I think. Practicality is an issue. Ideally, yes, we should have all these kept, but practicality is an issue. So I think maybe randomly we can do it. Dear sir, what do you think? That
what is practice at Arvind? We would really like to know.
The leftover probably can be kept for 2 days maximum, and that may help you to understand if there is a cluster, whether that organism has come from that. But medical legal point of view, that's not going to help you. So medical legally, only unused bottles belonging to that same batch, if they have contaminants, then you can take them to the court. Otherwise, it's not possible. So
Sir, I can add a point to that, sir. In one
Point
instance,
is, yes.
yes, sir, yeah. One
No,
instance, it was proven that the open bottle had the organism, and the argument was, it is already the sterility is lost. It has come during surgery into the bottle. That is the argument from their side. It is not from the bottle, it has gone to the patient. So that becomes very difficult to prove. Unopened bottle, if you can prove, then we can go against the company. But as I said earlier, Dr. Namrata Madam knows, that is one instance, it was proven that unopened bottles of ringer lactate had the same organism, same genetic composition, and the fellow manufacturer said it is not meant for intraocular use. So there was nothing we could say about that. Yes, Nirmal, sorry, go ahead.
No issues. Now, one more thing is you can't keep the biomedical wastage beyond 48 hours. So you have to discard them. So there is a bit of conflict here. So as per biomedical wastage 2018 guidelines, we have to discard them within 48 hours. It has to go out of our premises. And if you're going to have them, and if it is not stored properly, or if there is a mixing, then again the onus falls on us. So it's not a good advice to keep the used consumables in our premises.
Thank you, sir. Thank you.
what Nirmal says, what he says is what is being possible, on a day-to-day basis in our practice.
Yes, sir. And now I invite Dr. Chandrasekhar to give his talk on important do's and don'ts. And you all know Dr. Chandrasekhar doesn't need any introduction. Like almost every day, throughout the day, he is on some webinar or some class. So throughout India, he is a well-known person.
Thank you very much, madam. Greetings to all of you, all the learned faculty members here, and all those people who are attending on the webinar platform and YouTube. So this is going to be a talk on cluster endophthalmitis, do's and don'ts. It is not going to be any technical, but we are going to talk about what we should be doing and what we should not be doing. So one thing is, some of the images, some examples are from hospitals and net as examples only, nothing against any hospital or person and no financial interest. The doctors were treated as God model even a few decades back, but now we have gone into an era where it is a patient-centered approach. Now today, a person coming to practice after MBBS should be ready to face complications. There is no treatment without a complication, not only surgical, it can be even medical. So people awareness, thanks to the net, is much more, and they use it and probably misuse it to go against the healthcare system. So it is our mental strength that is needed to face it and come out strongly by certain measures, which was told by Dr. RDR sir and Nirmal, documentation, following protocols. If you have done things properly, but this mob attack and all those things are not at all in our control. Even at this point, nobody can control it. But at the end of the day, legally, we should be coming out strongly. This is something which has come very, very strong now, rights and responsibilities. And most of the cases in the court go with these things in mind. More than 50% of cases in India are lost because of improper consent forms or absent consent forms. This informed consent is not proper, and that is enough to finish the case off, even if you have done everything else properly. This is something which is happening and which should not be happening. When complication occurs, what happened only will be asked, or what did you do will be asked. You know, what did you do or what happened? It is not asked what happened. What did you do is assuming that you made a mistake, which is not good. Professionally also, this is happening between the colleagues. So it should be actually what happened, and then we need to find it. It reflects on the mental attitude of the person who is asking, and it will go a long way against the person's mind who is actually involved. Seeing a cluster endophthalmitis is really a nightmare of nightmares. So by definition, any surgical site infection within 30 days of surgery is a surgical site infection, where endophthalmitis is also one. But when we have an implant inside, it can go up to 90 days. So what are clusters? They say 3 to 5 cases in various books, but as Dr. Saravanan said, even 2 cases considered as a cluster. Even a single case or 2 may be a warning for a cluster to come. Even consecutive day cases will be called as clusters. Indian scenario, though we have seen some reports, clusters are occurring across the India. Many are not reported. Except the big organizations, the smaller people never respond. Very few publications are there. So really do not know actually what is the total scenario across the country. But today we have protocols which has been very nicely elaborated that makes us our infection rate to 1 in 10,000, less than 1 in 10,000. That means what? We have a wonderful protocol. But why do clusters occur? But we have to do 70 to 80 lakh surgeries a year. Camps are there. But when we do mass number of cases, there are some compromises we undertake, and we need to accept when these compromises are undertaken, the sterility can be broken. The sterility breakdown can occur. And that is why these clusters, we must understand one thing, any cluster occurs, it is iatrogenic. It is definitely iatrogenic, and the hospital acquired infection only it is, not anything endogenous. So where do they occur? It can be a single doctor, small hospital to a regional institute. Nothing is immune to cluster endophthalmitis. The source could be any of these things, starting from the person who's assisting. There was an instance in one of the smaller towns where the assisting nurse had a subclinical throat infection, and series of infections occurred over a period of 4 to 5 days. And then what happened? Everything else was negative. Then the microbiologist with whom we worked took a swab from all the OT staff, and that was sent. It was positive for an organism, and that was sent along with the cultured organism to Italy that point of time, and found out it was a subclinical throat infection which had caused the cluster. So everything is there, and it could be in the OT setup, it could be sterilization devices, personnel. Patient can also be a cause to cause infection, and it can spread to others. Of course, the environment we forget, not only inside the OT, surrounding the OT. Every other place is important inside the hospital. What happens now? When a cluster occurs, there is always an internal conflict, and even if we see one endophthalmitis, we know how our heart is going to thump. But when we see a cluster, the people who are operating and the management will definitely panic. It is very important that we don't panic. We have to identify this, and as pointed out beautifully by Dr. RTR sir and Dr. Shivakumar, recall is, you have to call every other person and see that you start early treatment, early management, which has been described beautifully earlier on. The findings should be documented. Another important thing is smaller hospitals, when they get 3 cases or 4 cases, they're scared to refer. They don't want it to go public. But that is not the way, because by delaying, we are only making the inevitable of making the patient blind, and the problem could become worse. Without hesitation, it is better to refer them to a higher center where the facilities are available. Informing authorities, according to Blindness Control Society, especially when mass blindness is going to occur or mass infections are occurring, especially with that of camps, including paying cases, you have to report to the District Blindness Control Society. And of course, you have to be very careful when you tackle attenders in cases of cluster endophthalmitis. Some of them can go violent. You may get multiple calls of threatening and so on and so forth. It has to be. So the most important thing I would advise, on day 1 itself, independently talk. Explain to and you also mark it in the case sheet that it has been explained. Even if not during the crisis, legally it will hold a very good value. To find the source and eliminate, prevent further catastrophes, manage, all these things have been dealt with as to how it has to be done by Dr. Lalita and everybody else. Now, when you are going to work up a patient, please do not keep a blind eye. Don't try to prove that there is no problem with the hospital. Try to find out what is the problem, because it has to be 100% in the system only. It may be the consumable, but still we are responsible because we get the consumable and we are doing. As it has been pointed out, there is a batch testing of some consumables which can be done before we put it into use. But we are not talking about that now. The infrastructure, how it is, whether the whole infrastructure of the hospital, the OT, whether it is a very good hospital infection control program, document protocols, and you have to also look for sterilization breakdown and so stuff. See, what happens is there would have been 1 or 2 instances of sterilization breakdown. One indicator is not seen, biological indicator. They just marked it. But in 1 or 2 cases of investigation, they found out that this was positive and no proper step was taken. Adia said, it is not important only to do that. Somebody at a higher level who's in charge of the OT or the doctor should monitor these things to prevent a catastrophe like a cluster endophthalmitis. Case sheet is very important. How you document, how you write, especially how you tell the patient and the attendant. Get their signature on day 1. It is easier. On day 4, day 5, we cannot get a signature. Informed consent is a must. But what is happening is some of the hospitals, they do camp surgeries. The informed consent is not as good as that of a paying. So as far as patients are concerned, NABH also tells that paying or free, all are equal. You treat them equally. Investigation scan and photos. Actually, for another case where an investigator had to go and explain the scan to the CBI. So there are all very important findings which will go towards your how you are going to manage a case of cluster. Minimum 2 or 3 times. They see once, they go, and next day they come is not acceptable. This is an emergency. Cluster endophthalmitis itself is an emergency. You have to make entries and expert management if it is available or referral. Everything should be mentioned and then sent. This consent form should be proper, and we are not going to talk about consent forms. There are many things about consent forms. It should be as per, we have so many examples, so many templates that have been distributed across, including at all India level. You have to shut down the OT once a cluster. There is no question of continuing the OT. The problem is when the cluster occurs late, we do not know. But Pseudomonas and all can occur within a day or 2. The complete workup, as already mentioned, do not forget the environment and water and all those things. Review all the protocols, validations. So how long will you see all these things is very important, which I will come shortly. When could they become a legal case? Please remember, today every case can become a legal case. And when it comes to endophthalmitis, any endophthalmitis and cluster is definitely a legal. But some of the hospitals can manage to come out of it with proper management, giving them all vision. Some of them go for early settlement. All these things are occurring even now in the country. So what happens? Suddenly one day, 3-4 people will join together. Nothing they will do. They'll go in front of the hospital and block the road. This is what has happened in a few instances. Or knowing about this, a lawyer will come, catch hold of them, will give them all some money and say, I will put a case. Whatever comes, this is the split up. So these things happen and they will run the case. Then what happens? There you may not even know. Somebody will call and say, your name is there in the TV. I'm seeing what is happening. So this is something which is you have to tackle attenders and public at that point of time. Media will be very difficult. You have to be prepared. You cannot avoid the media sometimes. Avoiding also may go against us. Be prepared for an investigation. Sometimes when it comes on TV, in one instance, it came on TV within that same evening. It came at 11:12. Before evening, 6 o'clock, there were 6 departments that have come. The main group will be the dean or the joint director, the surgeon, and that is the governmental team. Then the district blindness control or the state blindness control will come. The drug inspector will come and take the relevant drugs. Police, of course, they can be taken to the police station, or they may, some of them are very decent, they will come and investigate you. Human Rights Commission will also come, and as required by the court, it can be any agency, including the CBI. And what an inspection team will look for is a standard checklist. Now, importantly, it is prospective and retro. Prospective is from the time of occurrence, what all has happened. Retrospective, there could be a question, what is retrospective? We all think from the time of admission till the surgery. Definitely not. In one instance of cluster, they took the consumables, everything for the previous 2 years to see per case are they changing the gloves, to see whether they're changing the needle. So retrospectively, they collected data for 2 years. So anything should be documented. Most important, if everything from our side is good also, license, the Clinical Establishment Act, the Pollution Control Board, any of this is wrong, then the whole thing what you have done will become wrong. So this has to be always in place for any hospital. Environment would be checked, sterilization, autoclave and surveillance validation, medicines, consumables, personnel. In one instance, again, I'm telling only based on instances, 70 people were interviewed. 70 people were interviewed. All the people who are doing whatever they are should be very fluent with what they are doing, what to do when there is deviation. They also can investigate with the patient in places of cluster. So sequential documented evidences only will give us fantastic, positive report about what we are doing. The case record should be good. Everything should be documented. I think it has all been covered. The validations and surveillance, make sure none of this is negative, because that particular time when they come on it, they will find out one small thing 1 week earlier has been missed. That is enough. That is enough for them to go against us legally. These logbooks, who enters and whether all the people are, entering in the logbook, autoclave logbook, flash autoclave, medicine usage for recall, surveillance registers, all are very important. People involved in each of these processes should be very much aware how to take care of all these things, including, maintenance of the equipment, calibrating equipment, everything, AC maintenance, because sometimes the split ACs are still there in many hospitals. Maintenance of that is very important. Even that water leaking from split AC can be a major source for infection. Camps, this is something which sometimes has been a major problem. The permission should be sought for camp. DBCS will either send somebody or would have given permission. The camp organizers, patient, all these people were all investigated or inquired during one of the clusters. So everything you have to follow the protocol. How is the hospital affected? We will be closed mostly. It can be closed by the administration, or the hospital itself may shut down. Bad reputation. Sometimes the employee go jobless. There are some hospitals which have suffered for years. And the comeback is not going to be from zero again. It is going to be from -20 with sometimes a bad name coming. Surgeons have been threatened, have been assaulted. It is the people of co-professionals, our other patients, family who should give strength. It is a very difficult, traumatizing experience to face this situation. We have to come out of it. This is in one particular instance, wrong surgery performed, caused loss of one organ, forcefully retained the patient. These were that lawyer took this patient, there were 11 of them out of a possible 28, and he put the case as this. And there is something what we must know, protection for doctors to prevent arrest. So there are investigations that will happen by many agencies. Case can go for hearing. It is our duty that we are not negligent. It is our duty to prove there is no fault on this is something where we have to prove. This will not come overnight. The protocol should be there. It should have been followed. That will give us. So this Supreme Court order says unless they are inquired by the doctor or doctors qualified in the same branch, and then they say they are negligent or they say they are not negligent, only the action will be taken. If they are negligent only, then the court can give order to take a legal action on the doctor, because they don't want people who are not negligent also to be hurt by this. There is a Supreme Court order. Actually, if the doctor has hit somebody or something, then that becomes a criminal case. For medical purposes, nobody can be touched. This is something which every doctor in our country should know. What are the protocols we need to follow? So do we need to have NABH all the time? Not necessarily, but you need to follow protocols that are peer reviewed and which you have evidences that these protocols are good. So we have guidelines from AOS also, the second edition and so on and so forth. But here we need to agree that there are some amount of compromises to make sure that we do more surgeries, especially camp surgeries. But ideally, I would say the NABH will only give importance to only approved protocols. So at least the entry level, that is what the Insurance Regulatory Board will say. Entry level is mandatory. So minimal requirement, if you say, and that too NABH is being part of the Ministry of Commerce, it will have a lot of value in the court of law. We really offer very high standards of surgical skills to our patient, but we fall prey to infections because sometimes there are compromises at different levels, patients where the people may not realize what is the major problem that is going to come at the catastrophe. So maybe at a lower level, the person who is cleaning or something like that, so we may end up. So ultimately at this point in time, we need to say Whatever happens, there may be 50 people involved, but it is the surgeon only, because it is our duty to make sure that your tray has got an indicator which the color has changed or something like that. So this is something which has already been told. Document means you should have a protocol. If the protocol for that is not there, it is not done. If it is not recorded, it has not been done. This is only going to save us, and it should be consistently done regularly. So before surgery, case sheet workup, to summarize, systemic workup and informed consent. All this is very important. Then you need to have a retrospectively record of surveillance, record of consumables, and eliminate source if at all there is a problem which has occurred earlier, and prospectively patient management, documentation, referral if necessary, workup, and eliminate source. So these things are important. Now you must ask me one question. You have been telling only what to do. Important don't anything. Can anybody say? Don't is don't forget to do any of these things. And most important message of a don't is don't try to alter the case sheet or any of the evidences, because there may be always a chance that all these things would have been given as a copy to the person who is going to be affected. So that will go totally against, and even if you have done 100% things correctly, it will not help us. Do not try to tamper any of the records. That is very important. There are many of us, every doctor works, but the problem is, unless we review ourselves, update ourselves, and improve, we will not. Our dream is to have a 0% incident, but we are nearing, point not. We are going into 2 decimals and 3 and so on. It is good. Whether it's a dream or reality, we really don't know. But still, we need to know that this endophthalmitis can occur, and there is also a good chance of cluster occurring, even if we fail. Are we justified in sharing all these things, apron, gloves, tray, phaco, microscope? Now we have wonderful protocols to use it again, but in between sterilization process should be good. In between cleaning process should be good. Gone are those days, where we can start with 1 and finish 100 cases. But now these protocols should be done, but we cannot share certain things. Ultimately, whether it is one patient or a cluster of patients, we should not have an endophthalmitis. So cluster endophthalmitis, there is no immunity to any hospital or any doctor. So once it occurs, they have to be all the more careful not to get again. So this is something, we don't have failures. Your failures do not define you, but it can definitely step up your vigilance and your efforts and everything to prevent endophthalmitis and cluster. Thank you so much for your patient hearing.
Thank you, sir. Thank you very much. I invite Dr. Namrata Sharma to make a comment about this topic.
So, like always, it is wonderful to listen to Dr. Chandrasekhar, who every time emphasizes, what has to be done, what doesn't have to be done, because out of his practical experience, I think he knows it all. And every time the emphasis is that much, and each time, this talk really hits you hard that you should be doing this and these are the don'ts. So I don't think I have anything to, add to after what Dr. Chandrasekhar has said, which is a complete talk. And I think we need to give it again and again for people to, actually understand, because this is also out of his own anecdotal experiences and his own findings, his own investigations. So thank you so much, Dr.
Thank you. Thank you so much, madam. Thank you, madam.
Yeah.
I just wanted to say one thing, that the point that Dr. Chandrasekhar emphasized was mainly on proper documentation and don't tamper with the documents. That is something which is really very, very essential. Otherwise, if there's any tampering, then it will entirely spoil the whole thing. So I guess that is some message that can go to even small time practitioners, even the small level practitioners who are doing. They may say that I don't have an NBH accreditation, I don't have all these things, but if they document everything properly, and then in such a case, that is sort of a safety gadget for them, that the documentation is proper.
Thank you, sir.
Thank you.
And we take comments from Dr. Nirmal also, madam. He is now a lawyer.
Yes.
He is a legal expert.
Yes.
Dr. Nirmal, please.
Dr. Nirmal is
It's-
sort of a
You,
an
you
expert
already
in
covered
this.
everything, Chandrasekhar, right from the medical point of view, ophthalmologist point of view, legal point of view, and association point of view, crisis management. So you have covered it all. So nothing to add. Maybe after the next talk, we can take on with the AOS leadership here. So how to put the responsibility. So it's all the time on the doctors and really taking a toll on our mental and physical health. So it's somewhere associations have to pitch in other than conducting conferences. So where to put the responsibility about the supply chain? So generally companies take a responsibility up to their doorstep, right? So they do quality control and packing and then send off. And we have to take the responsibility from our doorstep. But in between, there is a huge supply chain involved. And this is where most of the problem happens. In vaccine industry, the industry takes care of the supply chain management, whether it's cold chain or the sterility or any adverse reactions. So same way, AOAS and all other associations have to come together and try to put the onus on the companies, manufacturers, and it is their responsibility to supply us a good product, quality control on the product, as well as sterilization, and also take care of the ADS, adverse drug reaction, because vaccine industry, as you've seen in the COVID period, have taken the entire responsibility of adverse drug reaction on themselves. Unfortunately, this we have not enforced on the supply chain system for ophthalmic consumables, particularly the BSS or the ringer lactate. So we have to come together. Maybe RDR sir can give his expert comment, and maybe we can listen to the oral lab manufacturer on what they have to say. And the item we have to put our heads together and work for it. Thank you.
Sir, Dr. RDR sir, any comments on this particular? Yes.
The point made by Nirmal is very important. So we have to really make sure. Now, the one way to get around that is to use products from reputed industries. That's what I try to advocate within the system. Not to change, from one company to another company without a proper reason. If you know that, if you have experienced good quality, consistency from a particular supplier, I think you have to stick to them. Very often when we change the companies, we can get into trouble as well. And because we also need to understand whether the product is being made by the company or it is being outsourced the production to somebody else. So that is also an issue. Sometimes when we want to buy in bulk, we also try to understand what they are. Because of our pharmaceutical connections, we try to understand who they are, where they are making it, how their system functions. So based on that also we decide on the supplier from where to buy. So all of that becomes important. I think prevention is better than going and fighting with them. So choosing appropriately is important. But the point made by Nirmal, I think we all need to work on that. How do we make sure that the people who supply the drugs to us for all this, the important intraocular surgeries, also take the responsibility to maintain the sterility of the product. Yeah.
Thank you, sir.
Yeah.
Just wanted to ask you, sir, and also Dr. Nirmal and Chandrasekhar, that some of these solutions, the company people, they get away, without having anything, because they say that it's not meant for intraocular use, but it is being used for intraocular surgery. So what's the solution for that?
I think we have a strong protocol on usage of off-label drugs, right? So Avastin, we had a certain system. Of course, it is legal as well as manufacturing issues. So we have to work with the other departments, particularly the pharmaceutical industry, to get out of this. And also the indication for each drug usage. I think as the end users, so we are basically the end users, and there is a huge industry working on it. So when they approve certain drug, so it is also involves the pharmaceutical industry and the legal system. So FDA has a set system on. This is where you can use the drug and you can't use off-label on certain conditions. But because of cost consideration, in our country, we are using off-label to a more than needed thing. So this off-label usage, since the industry themselves, the government is also promoting, right? For example, in a national program, the usage of ringer lactate is allowed, but the manufacturer escaped his responsibility, saying that it is off-label usage. So therein comes the associations where you have to work with them, engage them, that so the product has to be, the off-label usage has to be taken off. They have to approve it for the usage for intraocular also. So we have to work on this scale. So either we have to work with them or we have to fight them in the court of law, see to that we get the legal solution for it.
There is nothing prevents us the off-label use. As an ophthalmologist, if we understand, that there's a safety to the patient, we can use it. Like the example, ringer lactate has been, there's a lot of publications showing the safety of the ringer lactate. So we had gone to the DCGA authorities and showed them all of that. So what they are saying is that if the company people, if they apply for a intraocular use, they need to apply from the company producers. If they apply, they are willing to give. But if you go to the company, ask them, they are not willing to apply for that. They are not going to do it. They don't want to do it. So that's where the whole catch is. If the company is willing, I think we'll be able to get it from the DCGA. So
they don't want to get into it. That is a problem.
Yeah, they don't want to.
It's a commercial interest. So they don't want. They have that narrow commercial interest.
Yeah.
So as I had sent out mailers also from AIOS, and I think we are very soon planning a focus group meeting on off-label use of drugs in ophthalmology. So I think we can come out with a list which are off-label, and we have made a list. And if we come out as a society saying that our society, we are not saying approves, but uses these drugs off-label, then it kind of, I'm not saying it will help, but it will definitely, it will be a positive note for the ophthalmologists who are using off-label drugs, and who, if they are contested in the court of law, at least there is a list from the society which says that these are the drugs which can be used off-label for this particular indication. So I think that may also help if it comes from the society.
What you say,
Dr. Nirmal Frederick will tell us whether legally it is going to, I'm sure legally it probably is not going to be binding. It's kind of advisory kind of a thing, that this has been suggested by the society.
There may not be a legal binding on the numbers or the society. It could be a advisory from the society to the members on restricted usage, and maybe advocacy to the government saying that this is the work of the ophthalmic community for the betterment of the society to reduce the cost on the economic grounds, as well as providing affordable care. So we have to really bring out a white paper on this and convey it to the government in such a way that we are saving so much for the government in terms of foreign exchange, as well as giving affordable cost, and ask them to help us in making or streamlining the usage of the supply chain, as well as removing the off-label usage. And also proactively, we have to work with the companies that so many, we are using so much of drugs in that and giving them a good revenue. And why can't they apply to DGCA for taking off this off-label usage? So the issue is only the legal catch, and we have to work with both the partners, both the companies as well as government.
Thank you, sir. Thank you. And as the last talk of this session, I invite the Oro Lab to say how, once the complaint comes, how the industry will do, what the industry will do to help us.
Good evening to everyone. I think we are audible and our slides are visible.
Yes.
Thank you very much for giving us this opportunity to share how we are handling these complaints as an industry. Basically, this presentation will cover the process by which we are handling the complaints. We will not touch upon the cause of the issue or something. It is merely a process by which we will be handling the complaint. So this is what the presentation today. As you all know, the complaints are not same. It is all the complaints are not the same. Some of them are minor and some of them are major. The minor complaints, the approach and the process of handling them will be completely different from the way we handle the risky or very critical complaints. When it comes to endophthalmitis, it is needless to say it is a critical complaint. So we have to follow this, we have to handle this in a particular manner. For this, we have established and a curated process by which we try to handle this endophthalmitis related complaint. The essential point here is when we call it as a critical complaint, the essential point is we have to act very quickly. It is the time and the speed at which it is being handled. That is what the approach we take. The reason behind acting quickly and being very time bound is the reason is to contain the problem and to prevent the recurrence of the problem. Unlike the hospital, the onus on the manufacturer is really high. When some clusters happening, it is very much limited to the boundaries of the hospital. But when it is made on the product, then the product might have been supplied to many hospitals, not only within the country, it could have been exported to other countries. So the onus on the manufacturer is very big. So they have to act quickly and try to contain the complaint and prevent the recurrence. That is the approach which leads us to follow the endophthalmitis like complaints in a particular manner. So when there is a cluster happens, then it is normal and it is quite common to suspect on anything and everything, be it a product or the environment or the infrastructure, the AHUs, the product, everything. It is very quite common for the hospital to suspect everything, and it is the way one have to approach that complaint. So when the product is really used, whether it is a consumable or an implant, then it immediately conveyed to the manufacturer, and the manufacturer has to get into the problem and he has to every industry actually put forth. As I said, when it is a complaint and that also a critical or a major in nature, then it is not just one person can handle that complaint. As you have analyzed or investigated the cluster in the hospital, here in the company also there is a multiple team working on the complaint. As shown in the slide, there is a QA team, regulatory affairs, marketing, company microbiologist. Everything have to align towards addressing this complaint in a time-bound manner. That is the essence. And we also rely on expert committee because we are limited with the manufacturing expertise. So when it comes to complaints like endophthalmitis, we have to see from the clinical side too. So we rely on expert committee like doctors from Aravind Hospital or our key opinion leader. We have to rely on them in handling the complaints also. Next. When the complaint is being received, we have a dedicated email through which we tend to receive all the complaints. It is a quality@auralab.com. We encourage all the users, all the customers to lodge their complaint because we have a continuous monitoring on the email ID. So once it is received, it is our duty to acknowledge the complaint. So we have an approach and a policy that within 24 hours we have to acknowledge the complaint. If it is a serious complaint and we have a very shorter timeline, so that is how it is being followed. This particular issue is handled, complaint is basically handled by a quality team. We have a set of people who focus on handling the complaints alone. So number. Here, analyzing the complaint is very much possible with the help of the lot number only. So we always look for the lot number whenever we receive a complaint. Once the lot number is given, that is the key from which we can open the Pandora box of all the analyzing and investigating the complaint. When what we say as analyzing or investigating the complaint is, we rely on the batch manufacturing record, which is like the documentation which Dr. Sivakumar and Chandrasekhar sir talked about. We also have a lot of documentation at the time of producing the product. From the receipt of the raw material, even before that, choosing the vendor and qualifying the vendor of the raw material supply, everything is documented. So it goes into volumes. So the QA team review the entire document to see anything went wrong during the process. That is what the focus is given on analyzing and investigating. The batch manufacturing record will basically cover a lot of test reports, the sterilization cycle related information, the environmental conditions at which those products have been produced, and the people who have actually get into the production. These are all various information we have to analyze, and we have to identify, is there any pattern emerging from the documentation that we have missed something which is critically leading to the problem. That is what we call as analyzing and investigating the complaint. And here, as I said, the approach towards handling this complaint is little bit different. Apart from reviewing the batch records and all, we also inform the stores department or the warehouse at the manufacturing facility to stop supplying the product from the same lot number, suppose if it is available at the manufacturing facility. So the first and foremost action is to stop shipping the products from the warehouse of the same lot number, so that we are quarantining and it will not to lead to any kind of issues at the other hospital. So these are the some activities actually being led by the quality assurance department. And the next activity is handled by the microbiologist in the company. We have an in-house microbiological department which actually screening and surveying the environment in which we are producing the products, and that is all their routine activity. They test the water, the clean room, the bioburden on the product, and so many things they have to do it routinely. When complaint comes, actually we have a practice, actually it is mandated by the drug control department that the manufacturer has to retain samples from every batch, which can be sufficient to do 2 testings. That means it includes sterility test or physical parameter test or chemical test, whatever it may be. 2 sets of testing need to be done. The quantity should be sufficient enough to handle that 2 sets of testing. That should be retained as a retention sample. So every batch we have to take 30 or 40 product and we have to keep it in the retention sample room. We have an environment controlled room in which these samples are being stored, but we will not access it, that sample immediately. In case if we have any samples in the stock, or in case we have anything in the store, that will be accessed first and that will be tested. The microbiology will do the sterility testing and the lot test. These are the two tests they have to repeat on the same lot and try to figure out is there any compromise. Though sterility testing is a sample based testing, but this is the only opportunity we have to prove that the product is sterile. Next slide. The same way the marketing is also having a role to play. We have about 55 dealers and 50 plus people in the field. They keep watch whether is there any issue with any of our product. So once we receive the complaint, we will immediately alert all the dealers and all the field staff. So they will ensure that if there is any similar product from the same lot, we have another record called lot disbursement form. Every lot being dispersed from the manufacturing site, it is being captured in a particular record called lot disbursement form. Every lot will contain a lot disbursement form. It says where the products have been actually shipped, who has the product and what is the quantity they hold. That information we can figure out. That will be circulated to the field staff and to the dealers. In the dealers place, if they have any stock at their place, they will quarantine it. And in the similar way, the field staff will go to the hospital where the same lot has been supplied. They will talk to the purchase department and to the stores department, and they will try to quarantine all the unused samples. So this is the step they have to do. This is their role with respect to complaint handling. And finally, we also work with the hospital microbiologists. This being a major and critical complaint, we cannot just defend ourselves by testing or by proving that our product is not in any default. So we have to work with the hospital. We talk to the doctors and we talk to the microbiologist over there, and we try to understand if they have any other unused sample, and that will be taken for repeating the test. The normal issue what we find is, suppose if they want to repeat the sterility test, there is a protocol for testing the product for sterility testing in the parlance of pharmaceutical product. It has to be tested as per the pharmacopoeial monograph way. There is a United States pharmacopoeia which defines the way at which the sterility test has to be done. That is the way the sterility need to be done. So we work with the hospital microbiologist closely, and we request them to do the testing as per the USP method. In case if they have any suspicion on the product sterility. In many cases, we may not able to come to a common ground. So we suggest the hospital to send the samples to a third-party lab, which is NABL accredited lab. Already there are many such labs in India like A2Z or CIPRA labs in Hyderabad. It is all qualified. We recommend them to send the samples over there, and their results will be kind of a binding and final. This is how it is being handled. The regulatory department in the manufacturing unit is also having a role to play, because this being a medical product, we have a mandate that in case of any issue, we have to inform Ministry of Health of India and to the Drugs Control Department that our product has got such a issue. So they will also step in. It has to be notified within a particular time frame. That in India we have to inform them within 2-3 days. Otherwise, as soon as possible, we are aware of that problem, we have to intimate them. And furthermore, the products, basically the OBDs and all, being CE marked, and some of the products are registered in many countries. Then the manufacturer has to notify all the respective countries' Ministry of Health within the specified timelines. Maximum it is 5 days within which we have to inform them. so that they will take a call whether to inform the entire surgical fraternity about this issue, or they shall wait for a few more days before they announce it in a bigger community. So that is what the role of regulatory affairs with respect to communicating the complaint. At the end, the product may pass or fail. If the product is passing the test and it is at no fault, then our specialist with the QA team will visit the site and they will discuss and monitor the process being followed at the hospital. And this is not done on our own. Here is what we rely on here is where we rely on the expert team from the hospital. We get the support of the doctors over there, and they will be part of the team. We will visit the customer's hospital along with the clinical team. So then only we will be able to access their sterilization process, the records being followed over there, and we basically try to support the hospital to come out of the problem by identifying the cause of the issue. So this is how it is being followed with respect to the product being passing the test. In case if the product is failing the test, then it is our problem. That means we had to recall all the products. So far we have been notifying to the Ministry of Health, or we have been quarantining the samples at various level. If the product is failed, then we have no other way to but to recall the entire sample. Again, the regulatory norms are very strict that whatever has been supplied and what is the amount actually being consumed and the balance being recalled should be reconciliated. In case if it is not reconciliated, it is again offense for the company. So to ensure that the company is having the capability to recall the product in case of any emergency, we have a system called mock recall process. Every year we have to conduct a mock recall. This will go up to the dealer level, and the dealer again will talk to the hospital where he has supplied the product, and he will try to recall the product and send it back to our lab or any manufacturing unit within 3 days. We have to achieve the 100% of recall success within 3 days. It is a mandate. In case if we are not able to achieve that within 3 days, then there is a flaw in the recall system and we have to strengthen it. And once the products are recalled and reconciled, we have to identify the root cause by testing or by doing all the validation or whatever we can do. We have to even go back to the formulation stage, how we have formulated the drug, what was the issue, and is there any infrastructure related issue which is contributing for the problem. We have to holistically review everything, and we have to take appropriate corrective action. If it is a formulation, we have to change the formula. If it is an infrastructure, we have to correct them. Based on that, once we are thorough and we are sure that the product is okay and it is good enough to go to the market, we do the complete revalidation. Then only we will try to reintroduce the product. Again, when we reintroduce, it has to go through the legal review by the drug control department. As we have all discussed until now, endophthalmitis, it is not just because of the product alone. There are many factors which is really causing the endophthalmitis. So it has to be systematically investigated or analyzed. As you said, in the clinical side also there could be some chances. Even the storage and handling also plays a role which can compromise the product quality. And the product is having, though a role, it is very minimal compared to other factors which is really causing the endophthalmitis. As in the earlier speakers have spoke that prevention is better than cure, and it is strongly recommended. Oro marks, we have seen the video also. It comes handy. It is a prophylaxis, intracameral use antibiotic. it can minimize the occurrence. So that is what as a company we strongly advocating and requesting the hospitals. The price is also made affordable, and that is what we have been trying to convey. And the next slide. Even though we try to prevent, and it is again inevitable, the cluster of endophthalmitis is not completely preventable, and it can occur irrespective of all our efforts, be it a manufacturer or is a clinical team. Again, there is a possibility that it can resurface. So once it has occurred, then we all have the responsibility to solve it. We are to restore the vision as much as possible from the patient perspective. So Oral Lab has designed, it is again based on the inputs we have gotten from the Ophthalmic Society. It is not our own invention. We have got lot of inputs from Aravind and LVP and many other hospitals that Oral Lab should come up with one such kit, so that we have developed this kit. It has all the necessary medicines and accessories that needs at the time of emergency. So as a manufacturer, all our interest is to support or assist the doctors and the patients. The reason behind all our effort to support or assist the doctors and patients is they are the reason for our sole existence. So it is our duty, and we are supposed to do, and we want to do, and we continue to do with all your support. Thank you, sir.
Thank you, Krishna Kumar. I like to call Haripriya to make any comments about this, and also the rest of the panel, because till now we have been talking about involving the industry also, how to rope in them in the incident of a cluster endophthalmitis or any problem. So I would like to hear from everybody.
I think this is an important association to have. I think the industry also is trying to help us to look at active solutions. So I think it is a team effort, just like how we have to work with the association, the ophthalmologists, the industry. I think all together we have to look at solutions so we can give better care to the patient. I think I have nothing more to add.
One point I would like to make to the entire team, madam. We have been hearing the AHU or the AC is also contributing for the endophthalmitis. One point which came to my mind is the water system is also equally important. Cleaning the tank is all being now taken care. What is the missing piece here is, in case if we touch the pipelines, if it is not cleaned properly, we have a process called passivation. When the piping is being removed or reconnected or repaired, then it is important to do passivation. If we don't do, then there is a possibility of microbial breeding, especially the pathogens. The Pseudomonas, it is often identified even in the manufacturing side also. We have SS316 pipeline. It is completely sanitized once in a week using 80°C hot water. Irrespective of all these effort, if we do any repair, if we do any kind of a correction, we tend to find some kind of Pseudomonas coming into this because of contamination. So this can be addressed only by means of passivation. So we strongly recommend the pipelines need to be sanitized by using the hot water or by completely draining the pipes at the end of the day. There should not be any stagnancy of water. Even in the manufacturing unit, we have a slope. The pipelines are run in a sloped manner. So when we open the tap, all the water will be drained completely. There will not be any deadlock. So these are the some practices. So it came to my mind. So I would like to share it with you, sir.
I think that is a point well taken, which I don't know whether our people who are at the helm of affairs aware or not, but I think that is something which should be emphasized. And lot of things are done at the marketing level, which we've come to know only through your talk. Otherwise, we would not know, what goes into regulatory and how all the things, even at the level of the industry, are done. I'm sure it is going to be extremely crucial at the level of the industry also, because after all, if anything is contaminated or detected, then the onus comes on the industry.
Yeah, one more point, madam, with respect to the reuse of the unused products. Uh, in our industry, the auditors who come from abroad and even from the central government, if we have any unused, not for the clinical use, even for the analytical purpose or for any developmental purpose, everything has a life. Suppose we are not able to identify the life, we have to validate. For example, if I make a chemical which is used for analysis, I have to validate how long it is stable. Is stability is maintained. I want to use it for 7 days. Then I have to keep one product and validate by keeping it for 7 days. At the end of the seventh day, if I test it and if it passes all the parameter, then that is the we have to even reduce. If it is stable for 7 days, I have to use it only for 3 days. I am taking the little bit of cushion even by reducing the timeline. So that is the method being followed in the industry when we have some unused product or something.
So I think, Revati, shall we conclude?
I'd like to make one point alone.
Yes.
There is a system in India. You have got two programs. One is called the Pharmacovigilance Program of India under the Ministry of Health. Now that department is conducting a series of CMEs online to make awareness. So any drug with the name of the drug, the company and the batch number, if it is reported, and if there are similar reports, they take whatever action is needed. So that is becoming robust, and now it is online, the Pharmacovigilance Program of India. Similarly, there is a Materiovigilance Program for India, MEPI, that is for implants. So both these are going to take a huge step in managing drug-related reactions or any problems. So their identification of the same batch across the system, people are reluctant to tell. So this is going to be a very major boost in the years to come. Another thing I should tell is, he made a very valid point. In medical legal cases, the microbiological surveillance and workup report of the same institution, they don't accept. They want external lab investigations to validate. This has happened in one of the clusters.
Thank you, sir. And let us, we come to the conclusion of this wonderful session. And I thank every one of the panel as well as the speakers, especially Dr. Sinha and Dr. Sharma, who took the pains to come and join even late after being attending another very important meeting. And also I thank Dr. RDR sir and Dr. Nirmal for giving a lot of inputs. Of course, so many other than the regular, whatever we covered in the speeches, they gave extra points and extra informations, many of which would have been very useful for the people who were watching it. And as Dr. Lalita pointed out, there are from AOAS and from IJO, there were many articles as well as recommendations regarding this. I request all of you to go through them, that they will give a lot of insight to how to handle such a situation. Thank you very much. And also I thank Dr. Chandrasekhar, my co-moderator, for all the help.
Thank you so much.
Thank you, everybody. Good night.
Thank you, ma'am. Good night.
Thank you, Revati. Thank you, the entire team of the speakers, the panelists, especially the OroLab, who has sponsored this program. And we would like to have many more on the platform of this OroLab. And I would like to thank Mr. Siddiqui, who helped to coordinate this from OroLab, Dr. Anand and Ravi Mahendri, the audiovisual team, and our back office at the AIOS headquarters. Thank you.
Thank you.
Thank you.
Thank you. Good night.
Good night.
Good night.
Thank you.
Good night, everybody.
Thank you.